Hello, everyone. Good day, good morning, good afternoon, good evening. Thank you so much for attending this session, and thank you for making this event possible. We trust that the session from the previous chapters have been of your interest and have contributed meaningfully to your professional development. My name is Grace Wange. I'm an associate professor in public health from Monash University, Indonesia, and part of ISoP Indonesia chapter. I'm delighted to host this year's session for the South Asia, Indonesia, and China region. On behalf of the International Society of Pharmacovigilance, we are very pleased to welcome all of you to the sixth edition of the ISoP Patient Safety Day event that will be held on September 18 and 19. Ladies and gentlemen, as you know, the World Health Organization has designated every year on September 17 as the World Patient Safety Day to enhance public engagement in health safety and to promote global action aimed at preventing and reducing harm associated with healthcare delivery. This year, the theme that is chosen is Safe Care for Every Newborn and Every Child, under the slogan Patient Safety from the Start, to highlight the particular vulnerability of this age group to risk and harm resulting from unsafe care. In ISoP, we reaffirms this objective of WHO Global Patient Safety Challenge and calls on stakeholders and also health professionals to prioritize and take early action in critical areas associated with significant harm in pediatric and neonatal patients due to unsafe medication practices. These areas include high-risk medications, look-alike, sound-alike, or LASA drugs, dose conversion, care transitions, polypharmacy, adverse drug reactions, and other major disruption in the delivery of healthcare services. To start the event, we would like to listen first to our president, Dr. Angela Caro, that will address a few words to all of you. Please listen to her video.
Hi, my dear ISoP family. Welcome to the ISoP Patient Safety Day 2025. If you don't know me, I am Angela Caro. I am the president of the International Society of Pharmacovigilance. And with a big team, we prepared this day just for you. Thank you so much for your presence here. We are very proud about the talks and all the speakers that are invited this year in this celebration. Every year, ISoP celebrates the Patient Safety Day for the awareness of people who is working in Patient Safety Day and for everyone who wants to participate in create a better world in hospitals and industry and every place that is in charge of patient safety. This year, we are talking about the children, and we want to invite you to think how to contribute in a better medication safety for them. Please go to the social networks of ISoP and please read about all the information that we have for Patient Safety Day. And additionally, listen the EMC podcast that we create just for talking about this important day. Thank you so much for being here, and please enjoy the talks.
Thank you, Angela. Muchas gracias. So, ladies and gentlemen, as Angela said, we encourage you to contribute to the broader dialogue by sharing also your reflection of this webinar and also probably your experiences regarding this event through social media with the hashtag ISOPPSD 2025, World Patient Safety Day 2025, WPSD 2025, and also tag us at ISoP Online with another tag like pediatric safety, child safe care, and no harm from birth. So without further ado, tonight, or in my place, it's during the nighttime, I have two excellent speakers. Let me introduce the first one. The first speaker is Professor in Anesthesiology, Professor Sweta Viraj Salgaonkar. Hello, Sweta.
Hello.
Are you there? Hello.
Yeah. Yes.
Okay. And Sweta will tell us about pediatric anesthesia, how we can navigate safety. Sweta is a professor in anesthesiology and also pain consultant at SET, GSMC, and PAMH from Mumbai. She's a facilitator for FAST, Vital Anesthesia Simulation Training, and a fellow of Indian Academy of Pain Management, and also past associate editor in Journal of Postgraduate Medicine, Indian Journal of Pain. Her area of interest including difficult airway, pain management and awareness, and non-technical skill for anesthesiologists. So I will invite you during Sweta's presentation to participate actively by posting probably your questions and comments in the chat box. And later during the Q&A session, which is will be held after the second speaker, we will respond to some of your questions. Or also feel free if you want to post your question directly to Sweta. So Sweta, without further ado, please, the time is yours.
Yes. Yes. Thank you so much for your kind introduction, and I'll share the presentation. Yes. Yeah, so greetings to all from GS Medical College and KEM Hospital. This Twin Institute has entered its centenary year, and I'm so privileged to be associated with this for 3 decades. I congratulate ISoP for organizing this scientific webinar on such an extremely important topic of patient safety in pediatric population. And I thank the organizers for giving me this opportunity to share my views on how we navigate pediatric patients safely during the conduct of anesthesia. So the roadmap is going to be, why are we discussing this topic? What are the anatomical and physiological differences amongst between the children and the adults? Pharmacokinetics and pharmacodynamics, how are they different? What expert technical skills and non-technical skills which are required? The human factors involved in conduct of safe anesthesia, off-label use of drugs, and summary at the end. So we need to have a safe patient at the end of the surgery and anesthesia. So coming to why are we discussing this topic? Why this topic is chosen by ISoP? Well, for anesthesia in children, does it children do really mean they are miniature adults? Well, they constitute a diverse heterogeneous population from preterm neonates to postpubertal adolescents, and they are in different stages of development. Pharmacokinetics, dynamics are all different. Drug interactions also are different. There is polypharmacy involved in anesthesia. And many a times, this kids, they are getting exposed to first anesthetic, and they could be associated undiagnosed anomalies, allergies, which may get revealed only under anesthesia, and that's where there could be increased incidences of unanticipated issues. There is absent patient cooperation, as we understand, and small babies, big impacts means small periods of desaturation can cause major impact on neuronal functions, which can adversely affect immediate and long-term patient outcome. And we have paucity of clinical trials in children, and most of the drugs techniques that we use are extrapolation from the adult clinical research and trials. So that's the reason it's such an important thing that we are talking about. So for anesthesiologists, the airway management is the most crucial event during the entire anesthesia process. And what are the unique features of airway anatomy in pediatric patients, especially the young children? There is large occiput, large tongue, shorter mandible, higher larynx compared to adults, and all these can make these children prone to upper airway obstruction. They have small mandibular space, which makes the laryngoscopy very difficult. And epiglottis is U-shaped and floppy. They have subglottic area, which is narrow. That makes intubation difficult, which are very much required for airway control during anesthesia. And how do we mitigate this risk? We put the shoulder under the shoulder blade. We use straight blade of laryngoscope, and we use a smaller size endotracheal tube. What are the unique physiological and functional features that we see in these children? They are obligate nose breathers. They have low functional residual capacity. There is increased workload on diaphragm to maintain the tidal volume. So it gets easily compromised because of any stomach distension that can occur because of crying or mask ventilation. Chest wall is highly compliant and floppy. Respiratory center is sensitive to opioids and chemical stimuli. There is immature blood-brain barrier, and there is higher metabolic rate. All this gives us very low safe apnea time in children, and thus they are prone to desaturations and hypoxia. There is apnea susceptibility, so opioids are to be titrated. There is high oxygen demand. And how do we mitigate this risk? We continue oxygen, the alternate source of oxygen during anesthesia, that is peri-intubation oxygenation is on. There is gentle mask ventilation. The table is always put in the head up, 25-degree head up tilt. Airway gadgets, experts, and plan all are in place before the child is taken up in the OR. Guidelines and cognitive aids are used, and drugs are always titrated. There are unique further features are developing brain and spinal cord and neuronal connections. They are in the developmental stage. That makes the drug responses sometimes unpredictable, and even patient has unique pain experiences. There is dominant parasympathetic system, which makes them prone to bradycardia, where the heart rate of less than 60 is considered as a cardiac arrest in pediatric patients. There is immature organ function, which leads to delayed drug metabolism and excretion. There is developing immune system, immature coagulation cascade, and temperature regulation. All of this make them prone to recurrent infection, hypothermia, and coagulation. So how do we mitigate this risk? By optimal drug doses in regional and neuraxial blocks during conduct of general anesthesia, and even the IV fluid is like a drug, so the dosages have to be calculated very accurately. The parental separation is a very important aspect, and that we do it in a very pleasant way where the child does not cry excessively, which can make him or her prone to respiratory adverse events. So there is always very pleasant parental separation. Normothermia by active warming is always done, surface warming as well as core warming. Coming to pharmacokinetics and dynamics, we understand that children have a very different body composition. They have increased body water content, decreased muscle mass, increased volume of distribution. So the initial doses of the water-soluble drugs required are more, and there is but decreased organ function. So maintenance doses go down. There is low protein binding, so there is increased free fraction of drugs and delayed gastric emptying. So the absorption and peak effects of the orally administered drugs are slower. There is further increased sensitivity to neuromuscular blocking agents due to immature neuromuscular junctions. And this can have the consequences, like we know, because of the genetic susceptibility. There are many patients, pediatric patients, who can have a serious adverse event like malignant hyperthermia following dexamethasone, which is a depolarizing muscle relaxant, or because of the inhalational agents. There is decreased minimal alveolar concentration of inhalational anesthetics. So there is faster wash-in and faster wash-out. The in and out of anesthesia can happen fast. There is increased requirement of amide local anesthetics for spinal blocks. There is poor response to bronchodilators and prokinetics because of paucity of bronchial smooth muscles. And hyperoxia, that is FiO2 of 100%, especially in premature or neonates, can cause retinopathy in these patients. So there is possibility of under or overdosing in this patient. Now, children who has some congenital anomalies or syndromes, they present very peculiar problems, like patients who have got muscular dystrophies are prone to cardiac rhythm issues. Those who have vertebral, anorectal, and esophageal anomalies, they have this syndromic faces and maxillofacial issues, so they present with difficult airway, delayed recovery. Patients with hypertrophic obstructive cardiomyopathy or asymptomatic critical AS may face sudden death. Those with right to left shunt, like a tetralogy of Fellow, they are prone to air embolism, so their IV infusions have to be totally air free. Patients who have neonatal jaundice, they have altered drug metabolism and risk of hypoglycemia, convulsions, and the consequences. Childhood anemias are not uncommon, and that can make a patient more prone to post-surgical morbidity. The healing is affected. The critical incidents that commonly occur in pediatric patients during the conduct of anesthesia are the respiratory adverse events, the oxygen desaturations, airway obstruction, laryngospasm, especially because of inadequate depth of anesthesia or post-recovery. Laryngospasm is not an uncommon adverse event that we come across. Bronchospasm, apnea, airway trauma, or airway edema, vocal cord edemas can occur due to multiple intubation attempts. Other common problems, there can be medication errors because of the incorrect dosing, IV excess issues, cardiac arrhythmias, temperature regulation, post-op pain and delirium. Not to forget local anesthetic systemic toxicity, that is last because of any of the intravascular injection of local anesthetic or because of the overdose and the faster absorption. Malignant hyperthermia we already talked about. So this NAP4 project that was published in 2011, and it was about the major complications that can occur after the airway management, that said that most of the problems were because of the poor management rather than the problems of the technical skills. So, and NAP4 recommended the use of checklists and SOPs. So the subsequent paper that was published in 2012 also said that though we see the problems as failed intubation or extubation related problems or difficult or delayed intubation being the problem, why that failed intubation occurred or why that extubation related problem occurred is probably because we were not prepared adequately. There was a poor assessment, poor planning, closed loop communication probably was the problem teamwork and leadership or situational awareness was lost, critical thinking or dynamic decision making was delayed. So these are all the non-technical skills which are also extremely important in the conduct of anesthesia. So to understand non-technical skills, we understand what are human factors. That is how humans interact with the elements of the system, such as equipment, task, culture, and workspace. We understand that healthcare is a very complex system, and this is what we have to understand. The technical skills are very easy to understand, but non-technical skills are very subtle. So the system should be such that, and the training should be such that it should be easy for workers to do the right thing and difficult or impossible for them to do the wrong thing. So wherever we can fill the gap, we must do it. So there should be less reliance on the exceptional personal and team performances to provide safe and high quality patient care. The bottom line is the human factors are key to the safe delivery of the healthcare. What are human errors? Where an act of being wrong in conduct or judgment or ignorant or imprudent deviation from a code of behavior that fails to achieve what should be done. In anesthesia, a large number of errors are unredeemable and may reduce the possibility of an optimal outcome and hamper the patient's safety. Medical errors in anesthesia are associated with high rates of death, brain damage, less than appropriate care, and high cost. So when we talk about patient safety, definitely it cannot be without the talking about the Swiss cheese model or a Parmesan block model. So that is about here, Professor James Reason, he explained the stack of Swiss cheese to explain us the multiple levels of our healthcare system and where the holes represent the aspects of the workload, workflow, training, equipment, communication. And when the holes line up, as in multiple slices of Swiss cheese, a hazard or an error can become an accident. So to give that example, if the child is having the right kidney problem, and if for whatever reason, at the registration counter, for multiple reasons, that if it is noted down as left kidney problem, and if the resident, the surgical resident or the staff nurse in the ward or the anesthesiologist has not checked it, then the holes line up and the patient undergoes a wrong side nephrectomy. And that's a really morbid condition that we are pushing the patient into, that is really compromising the safety of the patient. So that's where he has tried to explain this very well. Other explanation is by Parmesan cheese model about the patient safety. There, every time a substandard practice is followed, an adverse incident may or may not occur immediately, but we shave off a piece from the patient's whole, and that decreases the chance of the optimal patient outcome. Like it is not as gross as we say the wrong side surgery here. If we say there's a prolonged or inadequately treated hypertension, that might be not sufficient to cause a life-threatening injury, but yes, it can cause an acute kidney injury, which may get converted into a chronic kidney disease. So this model represents the clinician's responsibility in routine patient care and importance of minimizing any deficiency in our day-to-day care practice. Not to forget about the errors of fixation. To err is human, we do understand that. And errors can occur regardless of the number of years of experience. So to give an example, sometimes you are fixated this and only this. Like in case if the infusion pump is giving alarm, we still keep flushing the line without realizing that IV could be out. It could be a misplaced IV cannula, or there could be a kink. Everything but this. For like, you are not looking for a wrong drug administration when the drug does not solve the problem. We have given atropine and there is no response to bradycardia. Everything is okay. Example, there is a low saturation and we say it is because of the equipment malfunction, or the finger is cold, or because of peripheral vasoconstriction, instead of thinking that the tube could be endobronchial. So there can be severe hypoxemia there. We can have biases. So there can be availability bias, tendency to judge things based on what comes to mind readily, depending on the previous bad experience. Like we have a high airway pressure due to bronchospasm, and we are managing it with bronchodilators, steroid puffs, and we are not ruling out a kinked endotracheal tube. Confirmation bias, where we are trying to force data to fit a desired or a suspected diagnosis. We keep repeatedly checking the blood pressure and changing the blood pressure cuff and not accepting that, yes, actually there is hypertension. Overconfidence bias, where we are technically not skilled or experienced and we are trying to guide someone else. Omission bias, there can be delay in ordering blood in spite that you know that the blood loss is ongoing, the blood pressure has fallen down, still there is a delay. So how do we mitigate these medical errors and enhance patient safety? Well, we must understand the complexity of the system. Routine checks are absolutely mandatory. We strengthen each layer of safety, as we said earlier. That's a primary prevention. We improve the workplace culture, flatten the team hierarchy, have the situational awareness, improve teamwork and communication, team pre-briefing and debriefing after every case, schedule the complex patients at the start of the OT list. I mean, surgically, the patient could be easy to go, but anesthesia-wise, if it's a challenge and difficult case, we must post in the first case in the morning. The favorable design of equipment and drug ampules and packaging, that's very important, because if it's not readable, we understand LASA and it can occur look alike, sound alike, drug errors can happen, and that can be really life-threatening. Training of all the healthcare OR teams and the healthcare workers should be there. There should be adherence to SOPs and protocols and cognitive aids. There has to be proper documentation. This is very important for secondary prevention. That means there should be reporting and, of course, non-punitive action for the healthcare workers. Regular audits should be there to prevent the human errors. There should be learning also from the successful cases. Root cause analysis should be done. Reflections should be done to prevent, again, the repeat in the future or near miss cases that happen. The staff work hours should be good. There should be good well-being. I mean, the well-being of the staff who are working. All these matters. And lastly, the indemnity insurance is tertiary prevention for the healthcare worker. Anesthesia is a team sport, and human factors are rarely in it, so we must learn them. The best way is a simulation, and of course in the routine daily practice it is good to discuss, analyze and reflect routinely. Error does not necessarily equate to harm, nor does an absence of error result in safety. So we must look at the individual component. We must not look at the individual component, but understand the healthcare as a system and try to improve that. As I think the next speaker is going to talk, we have limitations of research in pediatric, which is a vulnerable population, of course. So most of the research is extrapolated from the adults, which is usually based on the weight or body surface area. So a 60 kg adult is not equal to a 60 kg child. We have to remember that. There is lack of sufficient safety and efficacy data in children. The outcome measures are difficult to assess in pediatric patients many a times, and they are into developmental stages which can alter the action and response to a drug. So that's why there is more use of off-label use of drugs, and difficult and a challenge for the pharmaceutical industry to put the age-appropriate dosage forms and strengths. Coming to the off-label use of drug, yes, there are delays in updating these drug instructions and gaps in reporting and evidence of off-label drug recommendations in pediatric guidelines. So this is the editorial of the Indian Journal of Anesthesia 2015. It recommends that we should have evidence-based recommendations for off-label use. We should develop frameworks for assessing the risk and benefits of off-label drugs in children. We must train the physician the appropriate use of this off-label drugs and clarify the current evidence for pediatric off-label drug use and guidelines. Incorporate them in the pediatric guidelines to assist in the judicious use of this off-label drug. So before prescribing, we should be aware that it is off-label drug, and that is the only best option that we have, and there's no other option available. We must sign the patient's parents must sign the consent form, and the informed consent process should happen. There should be close monitoring all throughout when the patient is being administered this drug. There should be good documentation and reporting and publication whenever possible. So in spite of all these precautions, learning that we do, there can be crisis that we can face anytime during anesthesia. And that's why it's very important to understand the crisis resource management principles, never to forget this. In case of any critical incident or crisis, call for help early, establish leadership and role clarity, share the mental model, communicate effectively with a closed loop communication, distribute the workload, anticipate and plan, know your environment so that you can have gadgets or you can have people around to help you, allocate the attention wisely, mobilize resources and use them effectively, use cognitive aids to offload, because when in crisis, we are in the zone of freeze. Reevaluate and adapt. So this is extremely important. What we do is that when a patient goes through a surgical journey, we have to do a very detailed pre-anesthetic evaluation from the informant, parent, or any other family member, with the detailed antenatal history, birth history, vaccination, development, milestones, achievement, weight, growth chart, airway-related history, and examination. All this is done for the anesthesia risk stratification. And following this, informed consent process should happen. Informed consent is not simply a document, but it's a process where the consent is signed after the parents are explained the anesthesia plan and technique, what are the options available, what are the common minor complications, what are the rare major complications, if there's going to be need for blood transfusion, postoperatively ventilation, pain management, and likely postoperative course. What are the OT etiquettes that we must follow? Well, after the case is if the case is planned on the day of the surgery, the anesthesia workstation and monitor is checked, prepared, airway cart, drugs, IV fluids, and working suction. Everything is checked. OR team who is there with the expert anesthesiologist. Safety checklist is performed. Cognitive aids are handy and guidelines are handy. Pre-briefing is done with role allocation, who's going to do what. We share the mental model with the OR team. Parental separation is done by giving oral or intranasal or intravenous medication. Pre-oxygenation never skipped. Monitoring is done before we give any anesthetic, and IV infusion as per the calculation. We never back the monitor and at the same time insist on clinical monitoring. A very controlled extubation is done at the end of the surgery, and post anesthesia monitoring is continued for at least an hour in the ICU recovery room. So the patients, this is a patient who is there with us right from 2 years of age. He has been coming. Sorry. And they are very comfortable and uh, very comfortable with the OT environment and the people around. And it is done in a very playful way, which really makes them very comfortable. So we have to always have the patient-centric approach to administer safe anesthesia, and that can be achieved only when we have the expert technical skills along with the non-technical skills and understanding of human factors. How do we enhance the skills which are required for the smooth conduct? Well, bedside learnings, observations, reflections are definitely must, and workshops, especially hands-on workshops and simulation, that's the best way to learn because it's in a non-threatening environment. The patients are safe and still you learn the techniques the right way. So would just like to share a few cases. There was one 8-month-old child who was posted for cleft lip and palate when undiagnosed subglottic stenosis. So when we understood that we cannot intubate, it was a failed intubation. So we continued the mask ventilation, gentle mask ventilation, and we woke up the patient, reversed and woke up the patient, and tracheostomy was avoided. Multidisciplinary team was called for a pediatrician, a pediatric surgeon, an ENT surgeon. Everybody were called in, and of course, with the plastic surgeon was going to operate, and the parents, with everybody's consensus, we rescheduled the patient after the investigations, and that's how we avoided a kind of a complication, tracheostomy and its complications. We had another child who was 7-year-old Burns, who had a severe burns, post-burn contractures rather, by the time he presented to us, and had keloid tendency. And he underwent multiple contracture releases under general anesthesia with, of course, he was very extremely difficult. As you can see, there are a lot of contractures. This is still a released one. But when he was posted, now these patients do not even allow dressings under when they are awake. We need their cooperation, and that's why every time they come for a dressing change also, we need to give general anesthesia, which we do generally with the total intravenous anesthesia. And that's where we had once laryngospasm that can happen because of inadequate depth of anesthesia. So the learning from here was that previous uneventful anesthesia does not guarantee a similar course for your present anesthesia. So every time we assess a patient, we have to assess as a fresh case. There was one 11-year-old Burns patient who was there for delayed excision. And again, there was failed extubation in him. And we had to wake him up after we tried to put the supraglottic airway device, which is a rescue device. We use it at times, but it was not achieving the oxygenation that we wanted. So again, we allowed the patient to wake up and reschedule after acquiring a proper gadgets, that is a fiber optic bronchoscope, and then a senior person who could help us in achieving this intubation. There was a 35-day-old child for Sinike, where of course he had, because of the Sinike, there was no mouth opening. So this patient was again multidisciplinary team management. We had the ENT surgeon standby. But here I would like to insist, we did lignocaine topicalization, and airway was anesthetized topically, and thereafter even the transtracheal, as you see in the picture, we are giving a transtracheal injection in this baby. So the again, the child was done very well, and the release was done well by the plastic surgeon. This is one 8-year-old girl for TMJ ankylosis. Of course, this is post-surgery, almost 6 months post-surgery. She had portal vein hypertension and worry about the nasal intubation during the fiber optic. So we use vasoconstrictor and very gentle manipulation and done by the expert. So again, this was uneventful and good. We have this, the child, was in the previous slide where we saw the 4 photographs and the parental separation. That is this girl who had, when the first surgery was done at some other center, and she, ever since then, she had PTSD, and now we saw her, she was very comfortable sitting in the OR with in the receiving area with the mother, and comfortable with the anesthesiologist as well. So there are some of the cases that we come across, syndromic and neurofibromas. This being a tertiary care hospital, a lot of difficult cases reach us. So to summarize, we must remember that children are not miniature adults. They have unique anatomical, physiological, functional features and should be recognized for safe anesthesia management. Idiosyncratic reactions can occur to anesthetic drugs, and it may be the first anesthetic exposure. Detailed history and examination, informed consent process, planning, preparedness, expertise and equipment, and drug dose calculation. These are extremely important aspects of pediatric anesthesia and should be done as a routine. There cannot be any shortcut to it. The syringe labeling has to be proper. How the dilutions are done has to be standardized and uniform. Topicalization of the airway can reduce the airway-related complications, which are very common in pediatric patients, so this can be routinely followed. Every action should be directed towards the risk mitigation and patient safety. Technical skills, non-technical skills, and understanding of human factors are required for a safe conduct of anesthesia in children. Practice, reflections, drills, simulation, crisis resource management are answer to how we can enhance all the 3 skills. And an occasional pediatric anesthesiologist must take help from the expert in case of any anticipated difficulty or critical incident. So we understand that most of the problems are preventable, and that's why we must act in a way where the patient is most safe, because patient safety is paramount. So these are some of my references, and thank you very much for listening to me. Thanks for your kind
Thank you.
attention.
Thank you so much, Sweta. I think that's a really nice introduction also to the pediatric anesthesiologist and what kind of challenge that you face. I think I agree with you that we need a very systematic and good preparation before applications of anesthesiologist drugs. Please stay with us, Sweta, and I will again invite the audience. If you have burning questions, more than welcome. Just post your question in the chat column of your or YouTube channel or in the Facebook, and we're going to discuss further your questions later. I will invite now our second speaker. Let me introduce you to our second speaker, Professor Atia Faruqi. Professor Atia, you there?
Yeah, hi Grace.
Hi, yeah.
Hi
So,
everybody.
Hi. So, Professor Atia is a professor of pharmacology at St. John's Medical College in Bangalore. She will have a talk entitled Clinical Trials in Pediatric Populations. She's a professor in the Department of Pharmacology and completed her MBBS from Bangalore Medical College and also her master from CMC Vellore in 2006. She has been an investigator for different multinational sponsored and academic clinical trials, as well as an observational studies. And as apart from her routine academic work, she also set up and started the therapeutic drug monitoring services at St. John Medical College hospitals and in charge of the drug information services, and also play an active role in the drug and therapeutic committee at the hospital. I think she also have a keen interest in ethics and research and promoting a good research methods, which is quite interesting, especially if we have such a lack of knowledge actually about the research in children. And so without further ado, this is a very exciting topic. Professor Atia, the time is yours.
Thank you, Grace, for that kind introduction. I hope I am audible and my slides are visible.
Yes, it is.
All right. So, good evening, everybody. And I come here from representing my hospital, St. John's Medical College in Bangalore, South India. And ours is a 60 years old institution, and it has a medical college, a hospital, and an independent research institute. The research institute is about 20 years old, and it's the first research institute attached to a medical college. And we have also been recognized by the Government of India and ICMR as a center of excellence. And as a part of our Division of Clinical Research and Training in the Research Institute, we conduct health research method courses every year for the last 16 years and several other research methodology courses. Our division has been a part of large multicentric clinical trials, and I'm proud of being in the team of well-placed researchers. I do my bit of contribution in research as well as teaching. I teach in the medical school, nursing college, as well as we have a therapeutic drug monitoring laboratory in the hospital. So let me get started with this topic, clinical trials in pediatric population. And all of you know that pediatric population has unique challenges in their research. There are ethical complexities, there's difficulty in recruitment, or also limited funding in pediatric clinical trials as compared to adult funding. So I would like to introduce you to certain basic concepts, certain methodological issues, and few solutions, and what is practically possible. There are still some challenges, but we go ahead with our efforts to bring evidence. So I'll cover my talk in these subheadings: background of why we are doing this today, and what's the importance of pediatric trials, what are the issues with conduct of trials, especially design challenges. Ethical considerations are really important in this population. What are the regulatory framework, what do they say, and a few certain small solutions for the future. So clinical trials, as you all know, are systematic studies to evaluate safety and efficacy of new drugs, vaccines, or treatments. These RCTs, randomized clinical trials, are highest level of evaluation of any treatments. In fact, this is one of the greatest achievements of our modern medicine, that we are able to have evidence, and we use this evidence for proper care of our patients. And we all know that treatment guidelines are based on high quality RCTs. So guidelines for adults as well as pediatrics require good, robust data from well conducted randomized clinical trials. You see, this is a slide which shows a proportion of what is the disease burden, which is pediatric, and trials that are conducted in pediatric. So if you see that overall the disease burden, which is pediatric, is nearing 60%, but the number of trials that are in pediatric population are only 12%. Says the case is say with high income countries, and when you look at middle income countries, you have even lesser numbers. So while the disease burden is about 62% in pediatric age group in low and middle income countries, the number of trials that are available are only about less than 12%. And a condition which is primarily considered as diarrheal illness is considered as pediatric problem. 90.4% of it is pediatric burden. We have only less than 60% of trials which are conducted in this disease condition. So let me introduce to the concept of off-label use. We've heard this name before, so like a formal introduction. What is off-label use? It is prescription of drugs that are outside the specifications of the product license and for a different age, dose, route, or indication. So we know that we have historically children have been excluded from clinical trials, either due to ethical concerns, logistic complexities, or there are lack of financial incentives. So what we use our drugs are based on mostly as an empirical dosing or a scaling method. So all of us are familiar with scaling method where we use formulae based on age, formulae based on weight. Those are all scaling up methods. And when we use an adult dose and we try to scale it down to pediatric, we still don't have a, a complete scrutiny of that indication. So it is documented that 50 to 75% of drugs which are used in children are off-label. That means that we do not have a specific testing or testing of that drug in children or approval of those drugs in children as per the product license. Okay, so this is an off-label use because it is for a different age. The dose would be different and also route. Okay, I will talk about that a little later. We don't have enough, that is limited or sometimes non-existent so information supporting a given dose. So we are only using an empirical or a scaling dose. Okay. Now, what is the risk? If there is a risk of incorrect dosing, and there could be unexpected side effects. Incorrect dosing, because most of these scaling methods, which are based on age or weight, do not account for the differences in which the organs will deal with the medication. There is immature enzymes, there is different pharmacokinetics. So the dosing that we extrapolate from adults may need not be the correct dosing. And we all know that some children deal with some of these drugs with unexpected side effects. For example, with a simple antibiotic like chloramphenicol, we see gray baby syndrome, which is not there in adults. Tetracyclines are another important group of antibiotics which cause discoloration of teeth in children, but not so in adults. Okay. Similarly, the analgesic aspirin can cause Rey syndrome, that's involvement of the liver, which is an unexpected side effect of aspirin in children, not seen in adults. Okay, so overall, these by not having pediatric trials, we are actually bypassing the safeguards of drug regulatory process. All of us know that drug regulatory process is a very meticulous, thorough investigation to confirm the safety first and then efficacy of the drug in the given dose, in the given route for a particular patient. So an off-label use is dangerous because there can be errors in dosing or there can be unexpected side effects. Okay. So this puts the foundation of why pediatric trials. We already just now saw that we have paucity of data. And as Dr. Shweta had mentioned, children are not small adults. We cannot calculate exact doses for them. There are differences in absorption. This is kinetic differences. Their pharmacodynamics are undergoing developmental changes. This receptor sensitivity can be different. There are organ immaturities with liver, even elimination through kidney is impacted. So therefore, we say that traditional formulae for calculation of dose on weight and age do not account for these ontogenic changes. The ontogenic means growth and development and maturation of different enzymatic machinery as well as organ maturities. Then we have a difference in formulation for pediatrics, and the dosing therefore will also be different. There is an ethical necessity, just now, as I mentioned. If we don't have enough evidence for safety, then we can expect unexpected side effects. A well-designed trial, therefore, will help in creating safe, effective, and age-appropriate medicines, and also will identify and prevent adverse drug reactions in pediatric population. And as seen in with adult patients in clinical trials, participants in trials derive benefits by just being in the trial. They get better clinical care, and sometimes they have an access to new treatments, especially oncology trials. These treatments, which are not routinely available, may be accessible through the trials. Okay. So in conduct of pediatric trials, there are three things that we will look into. First would be the issues with the trial design. So there are certain challenges when we are designing these pediatric clinical trials. First and most important challenge is a small sample size. The number of patients, the number of children who are suffering from a disease condition or a particular cancer or rare genetic disorder would be fewer. Okay, so the numbers available are fewer, may not be enough to do a full-fledged trial. Plus, amongst the children, there is again age stratification, where we stratify them as neonates, infants, children, and adolescents. So there is a huge difference between neonates and infants, as well as neonates and adolescents. There can be a difference in their weight and their blood volume, the formulations that we can use for them, and the kind of pharmacokinetic responses that each of them will have. So when we are designing a trial, we have to look at all these, including all these age groups, or if we are focusing on one, then we need to specify that. And a third challenge would be to identify correct outcomes as endpoints and use certain biomarkers. We'll come to that in the next few slides. Now, if you want to get the right number, there are certain solutions. So I would be providing solutions by side as the challenges. The sample size can be increased by doing multi-center studies. There are global collaborations which help in getting people of similar research question together. It makes the trials feasible, and having a diverse population can increase the reliability of a trial. There is a consortium called Innovative Therapies for Children with Cancer, and this ITCC consortium can help build bridges between different countries and different hospitals for looking at a particular cancer of interest. The WHO has set up an international clinical trials registry platform. This again is set up for facilitating research across different geographical areas. There are certain other organizations, for example, Connect for Children, available here. C4C, it is called for short form. This again facilitates in bringing pediatric population of similar issues together and help in setting up trials which can be successful in getting adequate numbers required for sample size. Now, looking at what kind of outcomes should we see when we are designing a trial. Okay. So there are certain clinical endpoints which we can take as direct measure of clinical benefit, like a survival or a symptomatic relief or a disease abscess, that means complete cure of the disease. These are called clinical endpoints. And we compare this with surrogate endpoints. Now, surrogate endpoints are indirect measures, and these will predict clinical benefit. For example, certain biomarkers or intermediate biological measures. These can be also taken as an outcome for showing the clinical benefit, but it is an indirect measure. And also we have issues like I just mentioned, that we have 4 strata of children with size and age. And so we have to select age appropriate endpoints as well. Going a little more into outcomes, the clinical aspects versus surrogate endpoints. When we compare use in pediatric trials, clinical endpoints are preferable if they are feasible because they are more definitive. Surrogate endpoints are used when clinical endpoints are impractical or they are slow. Okay? there is no requirement of validation when you are taking a clinical endpoint because it is direct evidence. However, when we take surrogate endpoint, we require validation or strong evidence linking it to clinical outcome. And third is that trial success impact can be seen with true benefit and with a clinical endpoint, whereas surrogate endpoint will have to have a bit of a caution. There may be chances of misprediction if they are not validated, but validated surrogate endpoints are very practical solutions to looking at clinical endpoints in pediatric trials. Now, when we look at age-appropriate endpoints, there are several things that we can do. Okay, so we could look at developmental suitability. We can match endpoints to physical or cognitive developmental stages, and especially required for the different strata of children. Then validation and reliability can be done by using standardized, tested, and age-appropriate tools. Again, and there is a very important aspect in designing of pediatric trials, and that is called stakeholder engagement. So when we are designing a pediatric clinical trial, we include experts, we include patients, and certain times even caregivers when we are deciding and designing an endpoint. This helps in better identification of outcomes, benefit, and how it is practically applicable. We can adapt adult endpoints for looking at pediatric changes, and we need to, of course, consider pediatric differences. But we have seen that clinical trials which look at similar endpoints as adult clinical trials have been more successful. And last is that we could take multiple endpoints. We can combine the endpoint of clinical, pharmacodynamic, and also combine with patient reported outcomes or observed reported outcomes by the caregivers as endpoints. And this again needs to be age appropriate. So these were the challenges that we looked at, design challenges and certain strategies to help in identifying and writing the endpoints that we would want to and selecting them as age appropriate. Now, there are practical challenges, logistic, and what can be those? There are practical limitations of the amount of volume of blood, amount of blood that you can draw in at a time, and also total number of blood draws, pricks. So we know that when you do a pharmacokinetic study and we are looking at how the drug's journey is through the blood, we need multiple blood draws, and that may not be possible in smaller children. And with caution, we have to use for little older children as well. Okay. And again, as I said, weight determines, age determines, and there is this depiction which tells us the comparison. So this is a table which compares based on age, weight of the child as to what the normal circulating blood volume would be and maximum allowable sample over 2 weeks. So if you look at a preterm neonate, which is usually about 1.5 kgs, the maximum allowable blood draw in 2 weeks is only 3.6 ml. Okay, so that is really, really small. If you compare as you go up the size of the child and age, the weight increases, and a typical child of 12 years weighing 40 kgs up to 96 ml. So that is about 100 ml we could withdraw. So there is so much of variation in the amount of blood draw that we can do. And this data will reference us to what is allowable limit. Now, since there are these limitations, what can be the sampling innovations? So there are certain innovations which I'll talk about. One is an opportunistic sampling. Here we would try to reduce the number of pricks that a child would be getting. For example, for a routine blood test that the patient would have admitted in a hospital, for some other tests, we could do our sampling along with that sampling. So this is called opportunistic sampling, where we will try to reduce the pain and the anxiety with the number of pricks. Okay? Then we have a concept of micro volume sampling, as less as 300 to 400 microliters is enough for the newer machines that we have for analysis of the drugs. So we look at taking microsampling, and typically we can take it through scavenging of samples. That means that the blood tests that were done for others, when samples are left over, we could use those samples because we need very tiny sample. But of course, for a kinetic study, we need to know precise details of time of collection. So when we are given the precise time, we will be able to use these samples for evaluating or quantifying the drug in the blood. The concept of sparse sampling was introduced because of the advent of what we have, the model-informed precision dosing, that is based on pharmacokinetic, population pharmacokinetic data, and it has models for identifying the entire exposure of the drug using a few blood samples. We are using this sampling technique combined with model-informed precision dosing for our routine therapeutic drug management in our hospital. So that means that we take few samples, for example, vancomycin. We take 2 samples of vancomycin, and we are able to, using the software, calculate the total area under the curve. That means the total exposure of the antibiotic. We were able to calculate just by using using 2 samples with the software, whereas without the software, we would have needed about 10 samples. Using dried blood spots is another newer technique, and these require as less as 20 to 30 microliters of blood. Just only caveat is that the packed cell volume of the blood should be fine, the number of cells per area, so that we are able to get a good sample. There are certain other practical challenges. There are formulation challenges. It means we need to have syrups which are palatable, okay? And the dosing has to be correct with that formulation. Dose accuracy, as I discussed earlier, there is a wide variation in weight, and therefore this can be a challenge when there is different formulation. Administration of the drugs depends on taste, palatability, number of times, frequency. Certain newer formulation like mini tablets, chewables, orodispersibles, liquid formulations try to overcome these challenges. And the third important thing in pediatric trials is that we need long-term follow-up, because we need to see what are the effects of the drug on the child's growth at that particular age and also development. So safety monitoring is most foremost, and this is why we are talking about pediatric clinical trials on this patient safety day. When we do typical pediatric trials, we need to have certain safeguards with us. The most important thing is that we should have a data safety monitoring board which provides an independent oversight on the safety and success or going towards some successful, meaningful conclusion of any pediatric trial. Adverse events reporting becomes again very, very important during our pediatric clinical trial, as I mentioned earlier, that there are certain differences seen in children, certain certain reactions seen in response to regular drugs, which is not seen in adults. And long-term follow-up, as I just mentioned, we need to monitor growth, neurodevelopment, puberty, long-term safety. All these are very, very critical for pediatric clinical trials. Now we come to an important aspect of ethical considerations, and many times, as I mentioned earlier, ethical complexities make the sponsors think twice and whether to include pediatric population at all. But keeping it very simple, let me just take you through a couple of slides of what is important. Vulnerability of children. They are vulnerable because they have no legal capacity and they need care. They are dependent on others for their well-being. So we need stronger safeguards. The trial should be done in child-friendly settings, in the presence of parents, where they have emotional security. And we have to balance risks and benefit. And the body which is actually entrusted with this identifying balancing of risks and benefits is the ethics committee. So an ethics committee will do a meticulous review. They do go thoroughly into the procedures and especially for measures that will safeguard the children participating. There has to be a justification for participation of children, and a consent process should be in place. A little bit more detail of what an informed consent means for children. Consent process, usually the moment we think of a trial and we think of including a patient, we need to first get the consent from parents or legally authorized guardians. Then we have a provision of something called assent. So assent is like informing the child and taking permission from the child for participating in the research. And this actually upholds the important ethical principle of autonomy. So although a child is as small as 7 years old, totally dependent, will look at her or his or her parents for their consent, but a child of that age and then adolescents like 12 to 18 years are in capacity of understanding a bit. So we speak to them in a language that they understand. For children who are between 7 and 12 years, we can take a verbal or an oral assent, and we use visual aids like diagrams, infographics, or certain videos to explain complex concepts more effectively. One of the important resource that is available on the net, which you all can look at, is something called Sophie's Science Project. This is a cartoon depiction of what the whole trial is to make the child understand what a research study is. This has been developed by the Cincinnati Children's Foundation and Children's Hospital Boston. This is available as free tool in the on the internet, and it takes the child through using infographics, cartoons to make them understand complex concepts in simple language. So the bottom line is that verbal oral assent should be as simple as possible for a child to understand what is being asked of him when he or she participates in the trial. This assent should be obtained in the presence of parents, okay, and it also should be recorded for safeguarding the investigators. For children between 12 and 18 years, they are at a level which they can understand a little better. And so we take a written assent from them. This written assent is similar to the informed consent document for the parents, but in a simpler language, which can be understood by the child. And this also needs to be signed by the parents once you finish the written assent. Now we look at the other parts of it, which is the regulatory framework. So we have a guidance from ICH. The document is called ICH E11. It has undergone revision 1, and that's the latest still available as of now. This gives us guidance on clinical investigation of medicinal products in the pediatric population. So this ICH is the reference that we can go to when we need to design and conduct a pediatric clinical trial in case of any questions on procedures and rights of participants. All information is given in this document. Similarly, across the globe, we have regulatory framework, and I'll just mention a few of them, what are available, and we can reference them, use them for going forward with our design and conduct. National Institute of Health has a policy. The NIH in the US has a policy of inclusion of children in all human subjects, supported by NIH. The US FDA has come with the Pediatric Research Equity Act, and this tells all the pharmaceutical firms to include children in studies of all relevant indications. Where they are not going to include children, they need to justify why children are not included in this particular evaluation of a new drug. Okay. There is another act called Best Pharmaceuticals for Children Act, BPCA, by the US FDA, and this helps in incentivizing research in children, and they do by additional marketing exclusivity to sponsors who voluntarily complete pediatric clinical studies. Now, this is additional marketing exclusivity for about 6 months or more is there to keep research, to keep the financial interests of the sponsors. They have invested a little more in including children, and therefore they can be given exclusivity for their marketing. Both of these are for improving research in pediatric patients, okay, pediatric populations. Certain other agencies like European Medicine Agency has given guidance on pediatric investigation plan. It's called PIP, and it ensures the data is generated to support authorization of new medicine from pediatric population. It obligates companies to screen every new product for a potential pediatric use. And WHO has an initiative where it helps in boosting availability of drugs for pediatric treatment, accelerating research, development, and access to pediatric medicines. There are certain regulations in India, and I would like to highlight that because it emphasizes child-specific protections in research. And here the guidance is that children are permitted to be a part of the research only if safety has been established in adult population, or if the information is likely to be generated which cannot be obtained by other means. The ethics committee needs to approve after thoroughly looking at safety and rights of pediatric patients, and also that rights of participants are protected and compensation for trial-related harms are addressed. Certain special populations, which I will not go through in detail, but that they have unique physiology, neonates, those with chronic illness like oncology or rare diseases, nutrition status matters in clinical trials, and certain children who are more vulnerable, like orphans, socially vulnerable, they're orphans or they're disabled, also needs to be considered. So here we have three success stories of clinical trials in children. Vaccine, we've had the rotavirus with us, we have the HPV vaccine with us, all is possible because of improved child health worldwide. Antiretrovirals have helped us in dosing safely HIV children, and oncology trials are the ones because of which we are able to improve 5-year survival from 25% to more than 70% as a result of multi-center trials. So I would like to conclude by saying that negatively biased media coverage about clinical trials in children has to be balanced with public awareness campaigns, positive stories of societal benefits of RCTs, and we have to highlight the harm that can happen if we use not if we use adult data. That means if you don't use data from pediatric clinical trials, there could be unexpected adverse effects. Okay, so there is one additional thing which I would like to inform you is that now we are basing a lot of our trials on in silico pharmacology, also called as computational therapeutics or computational pharmacology. And this is on the basis of what I was talking about, sparse sampling using a computer software. So using softwares to capture, analyze, and integrate biological medical data. And we have two modeling approaches. One is called population pharmacokinetics, and the other is called physiologically based pharmacokinetic modeling, PBPK. And these are applicable to both pediatric and adult clinical trials. Summary to end with, pediatric trials are essential to ensure safe and effective treatments for children, must balance protection and innovation. And in future, we are looking forward to safer, child-friendly, globally coordinated trials. I would end here with my references, quite a lot of them, and thank you.
Thank you so much, Professor Atia. Very extensive elaboration on how we can conduct clinical trials among children. I saw that in the chat box, some people already have questions, but I would like to invite again Dr. Swita, Professor Swita, and also Prof. Atia to our discussion session. Before we go to the audience question, I actually have a personal questions that I would like to also ask, especially Dr. Sweta, because I
Yes.
think both of you actually mentioned that most of the drug that we use is actually off-label for pediatrics, right? So I'm just wondering, I'm just curious, how will you explain about off-label to the parents and also to the children if they can give assent? Maybe you can share also the experience, Professor Sweta.
Yeah, so when we are using these drugs, we have to, as I mentioned in the informed consent, that these drugs, we do not have the trials or the research for that. So, but without this, we do not have an option. As I said before, prescribing any off-label, we should be clear that it is the only option or it's the best option that's available. And we also explain that this is being routinely used in clinical practice, though there are no clinical trials being there. And we have done many cases where they have been very safe in these pediatric patients. So that has to be the way, that's how we explain them. And when the off-label is just one component of informed consent. When we talk about the other things, they do understand, the parents do understand that whatever we are doing or we are talking and we are going to ultimately conduct the anesthesia, it's all in the best interest of the child. They do understand our intentions and motive, and beyond that, they many a times they tell whatever is the best for the child, we give you the authority to do it. That is how they have that kind of faith in us, because they've seen us how we are dealing with the child, what all we are inquiring, what are our concerns. So that's the kind of connect we have with the patient. As I said, informed consent is a process, it's just not a document. So off-label use of drug also becomes just one part of the informed consent. And when we do this, there is always a positive response that we have seen from the patients. There could be some more questions that may come from them, that will it be safe, or you think that what will happen to my child in this drugs are used. Then we explain them, we give them the opportunity to ask more questions and get it clarified. But sometimes if they are not ready for regional anesthesia, then we explain, we change our techniques also. So we always offer them all the possible options that they have it. And at the end, if at all, I have to say, I will say that if it was my child, I would have gone ahead with this. So that's the final thing that I would say, and then leave it on to them to decide, because we are only the trustees. Ultimately, they have to take the decision. So it's always left onto them. And I always like to share all my thoughts. I think aloud with the parents and I discuss everything with the parents. So the decision has to be coming from there. So even if there's a problem that has come later on, the parents are convinced that it was done in the best way, basically, that there was no negligence from our side or any shortcomings from our side. That is what they understand. So the what you say, that bitterness is not there. They do have faith that our intent are correct. Yeah, so that's how we go about explaining the off-label use of drugs.
Yeah, thank you, Professor Sweta. I think, yeah, that's good communication will increase trust, and that's the key to kind of
So
asking for
can
a
I
consent.
can
Yeah,
I just
sure,
add to
sure,
that?
Professor. Yeah,
So,
sure, go ahead. Yeah.
so while I described off-label use for children, I did talk about it that nearly 50 to 75% of drugs that we use in children don't have regulatory approval. Okay, that means we don't
Yeah.
have direct evidence from well-conducted RCTs on their use. These are scaled up doses, so we calculate based on age and weight. Whenever we do use these drugs, it is not like it's illegal. In fact, that would be the only drug which is available, and it is pretty appropriate to use. Okay. The only issue here, and why we emphasized on off-label, is that there are times when certain side effects that could have been picked up if it had undergone regulatory trial, regulatory process, because it's quite stringent to go through the trial. They look at the benefits, they look at the risks, what is the advantage, how much benefit has happened with the drug. And so the confidence in its safety is that much better. But such trials, the drugs available from such trials only are about 25 to 50% only. So, as I said, nearly a rather larger number of drugs which we use in children are still off-label, and we call that as empirical use. We calculate using the scaled formula, but it's not inappropriate. Okay? So that's something which we need to convince the patients.
Yeah, thank you, Professor, for the additional question. So actually, I want to follow up also to that. So did you see a lot of challenge also in convincing the regulatory and starting your trials using those basically off-label use? Or is it even simpler if you can convince them that it's already actually appropriate in
Yes,
other country or
it's
setting? Yeah.
no. See, the thing is that when we are looking at focused trial of particular drug, it is going to be beneficial. So the regulatory don't have a problem. What they are looking at, regulators are looking at, is whether enough safety measures for the patient are there, including ethical principles being upheld, and monitoring of adverse events. Like I said, if you have a data safety monitoring board along with the trial, that is an independent committee looking at how the trial is going, what are the outcomes reported, safety is being established, then that gives the confidence to the regulators. Okay, so doing a pediatric trial actually is encouraged because we need more trials and we need more evidence. Like I mentioned, in India, we have this limitation that we can use or we can conduct a pediatric clinical trial only after the drug has been tested in adult population. It has been tested as safe and the dose has been identified. Only then can we do a pediatric clinical trial in India. Okay, but globally there are certain trials which actually take both adult and children together, and they have, of course, different versions of consent and consent added to that. But many trials which are looking at the same outcome measures are successful. So doing pediatric clinical trials is lesser of a problem from regulatory aspect.
Okay, I can see that.
So can
So
I
there's
just
a
add
question.
to
Yeah,
add
sure.
to
Go
that?
ahead. Go ahead, Professor.
Just yeah. So just that in pediatric trials or otherwise, wherever there is vulnerable population involved, there is always we have this on-site supervision also going on. The ethics committee will go to the on-site and check the papers, and they will interact with patient also. That can increase the safety. Apart from looking at the documents, the primary documents, they will interact with the patients also. So that can be an additional thing that can ensure that whatever has been conveyed to the ethics committee is actually there. And they have given the direct number, the patients are given the direct number of the ethics committee if they want to report anything or have any doubts about any regarding the drug issues or the trial related stuff. So on-site visits are generally a good idea for vulnerable populations.
So did you see, the Professor Svita, that actually the ethics committee monitor the trials actually more often than if they do for the adults trials, or are they the same?
No, they definitely, all vulnerable population, whether it's pediatric patients, pregnant patients, so they will definitely have the on-site visits for that. That's what we have seen.
Okay, thank you. So there's two questions actually from the audience online. The first question is from Ani Wulandari. She asks about risk management plan. So I think this is a question especially for Profetia. When you're conducting a clinical trial for children, is it required for you to submit a risk management plan? What was your experience?
Yes. Risk management plan is definitely required because there is an additional scrutiny, and more people are worried about whether safety measures are in place. and expecting the unexpected adverse effects. So we will need to gain the confidence by submitting a well described risk management plan. So we identify the potential adverse effects and uh, plans for unexpected events. Then, like Dr. Shweta said, ethics committee has a closer scrutiny on these trials which have vulnerable population, and reporting of any adverse event and uh, such issues have to be done to both ethics committee and to the regulator within a stipulated time. So, very critical document for all trials, especially pediatric clinical trials.
Okay, thank you. Dr. Sweeta, do you have anything to add? Have you encountered this like a risk management activities in clinics, especially for
Yeah, definitely. So because of that,
yeah.
to take care of the risk management, many a times even anesthesia person is made part of the trial for the resuscitation required or any adverse event that can come up. So many of we become the co-investigator to them because we help them for being standby for any of this serious adverse events that can come up. One worry that I generally that we have here for pediatric trial in India, otherwise I think the problems about the inducement, that is one big thing about the parents. So that can also kind of compromise the, of course, it's a vulnerable population, so we understand that the safety does get compromised here. So that is one worrisome thing to go ahead with the pediatric trial. So those things have to be very stringent, that the inclusion exclusion criteria should be very clear.
Thank you. So there's another question from Fishalani Devi Rashevan. The question is actually for Professor Atia, but I think this is also can be valid for Professor Swita. The question is, in neonatal and infant trials, the trial duration become a major challenge because of it influences the growth and development changes after the alter the PKPD themselves, right? I think you mentioned this also, Prof. Tia, in your presentation somehow. How will you address this? And maybe for Professor Swita also, whether if you look at your patient who will participate in clinical trials, will that how long will actually you follow up for serious adverse events, especially if we expect some late onset adverse events? So maybe any of you want to respond to that first?
Yes, see, I have already mentioned that follow-up safety data is really, really important for pediatric uh, trials. So it makes, so it really depends on the kind of research question that is there and the kind of intervention that is there. So for a drug and intervention which is of acute origin, that means you do it for a short while and then you look at outcomes. The probability of requirement for a long-term follow-up will be less. But again, it depends on the nature of the drug again. When you're looking at neonatal and infants, the question has to be very, very clear as to what what is your outcome that you're going to monitor. Okay, if your outcome, as I said, in acute setting is a short-term outcome, that has to be identified and reported. Further, as a safety measure, you will do a follow-up for growth monitoring as late as, I mean, as long as at least 3 months if for a short-term trial. But if it is a longer-term trial, for example, you have a tuberculosis, which you're looking at in children, okay, with children between 2 and 4, or maybe infants between less than one year. There you have an impact on the liver parameters, you have an impact on the growth, you have an impact on the vision of the child. Okay, so a longer follow-up will be mandated. children who are adolescents, we can expect certain treatments depending on the nature of the drug, where you're going to extrapolate from adult data, whether there is going to be an impact on growth and development, puberty onset. Those become important. Okay, so the duration of trial as well as follow-up for safety depends on the nature of research and the molecule that we are going to use. So, like I said, if we are using, if we're going to do a trial in children after an adult safety has been established, more or less a kinetics for the thing and the entire exposure to the drug will be also quite documented as to how much can it impact the children. But given the variety or rather age range of pediatric trials from neonates to adolescents, there it really will be dependent on the type of trial as I mentioned earlier. So that's from my side. Dr. Shweta, please add some more.
Yeah, this is one very difficult question always, how long to follow up with the patients. Like if my student, if I want to do just an observational study to see how anesthesia affects the neurocognition as a child is growing, uh, the the MD residence, we have 3 years residency. So I can do follow-up for 2 years and then decide. But 2 years, we know it's not sufficient to understand the long-term outcome. And of course, the criterias are also very difficult. But definitely, there's so much of talk going on about whether to, if they exposed to anesthesia and all these polypharmacy drugs much early in life, what has been their neurocognition, how do they get affected? I mean, most of the time, gross functions remain normal, but you will never know what happens to the finer functions. It is very difficult to make out. So the only thing as a clinician I would suggest is that what I follow, so I'm just sharing the same with you, that when we are managing anesthesia at that point of time, we try and keep the parameters, what were there as pre-op, always remain in 10 to 20% of the range rather than going to allowing them to go extreme. Like saturation is remaining 99 to 100. You see to it that you never want to get it down below 96, because otherwise, child will come out fine of anesthesia even if it goes below 96. But I don't know which finer functions would have got affected ultimately. So this is always a concern. And as a clinician, what I try and do is that maintain the parameters, but it is extremely difficult to say how long we can get we need to monitor them to understand what could be the side effects. But I guess if the neonate is there up to 3 years of age, you will see most of the milestones being achieved. Or if a toddler is there, maybe five years of age, you will see most of the things being presented. So somewhere it's just by a very what you say, as we've seen the patient. So very casually, I'm telling this, there is no reference or evidence, but that's what we have seen, that at least up to 3 years, one has to be monitoring if we are looking at some neurocognitive effects.
Yeah, so then it's kind of a difficult. Yeah, I know this is a difficult question, but it will be interesting if later we can have some kind of guidelines regarding this. I still invite people, if you audience, if you want to post questions. But I have another questions actually for Dr. Professor Swita, and also maybe Prof. Atia, you can later add on. It's about the dosing. I mean, like, because we know that error in dosing is kind of the major causes of medical errors. And of course, in pediatric, there will be more challenges because we don't have the dosing form, right, for the children. So what was your experience in this? Like how difficult it is to actually adjust the dosing, and how we can actually, limit the medical error related to the dosing calculation, because I understood it in clinic will be a very challenging issues coming from a adult dosing and then convert that to the pediatric dosing.
very true. The dosing is really a sorry, dosing is really a problem. Though the standard doses are defined, but many times the calculations go wrong. So before we take any patients, we see to it that it is double checked, that the dosages are calculated correctly, because it's a mathematical thing and you cannot have, because I've seen if the child had to be given kind of 0.3 milligram of pentazocine, this is way back, and if the child receives, because of that one decimal, child receives 3 milligram, and it's like patient will go on ventilator, the neonate will go on a ventilator post-operatively. So we have to see to it that the drug chart is put up, calculated, and it is put up before any pediatric patient is taken up. All drug dosages, all the drugs that we are likely to use are calculated as per the weight, and they are put up. And the dilution of the drug that we do for pediatric patient, it's done in that tuberculin syringe, so that and it is standard, uniform all over the hospital, so that there is no confusion about the change in the concentration that can give problem, because sometimes some of the residents may have habit of diluting it 10 times, some may have diluting it 5 times, and you don't know per ml how much is going. And in pediatric and neonates, definitely we do not want to increase the volume. So what we use is, we use the tuberculin syringes where the marks are graduated, and that's where everyone uses the same protocol all over the hospital. And some of the drugs are put up in particular syringes, like if it is atropine, then it is there in say 2 ml syringe. And if there are muscle relaxants, they are labeled in red, so that there cannot be any confusion about a wrong drug going, because many times a flush is used, and relaxants have sometimes can go if it is not labeled correctly. So we know the relaxant is the most dangerous drug for us, so we keep it in a red label, so that everybody knows. And it is good to have that uniform practice all over the hospital, so that we can avoid this. And as we understand, LASA is very common. So, so we use even the magnifying glass at times, so that we can see the strength, or we can see the expiry and the date, because many a times they are not even readable correctly. So that's why it is important. So we use magnifying glass, which is kept with the anesthesia workstation. So, and it is, drugs are always confirmed by two people. So two in the team will always confirm the drug. And yeah, that's the way we try and reduce the drug errors. And we have to talk also that this is, if somebody is giving the drug, that person will say this is 2 milligram per ml, and the expiry is so and so. The other person will also see it, that yeah, confirm, not just listen, but will counter check and see on the label that yet it is. So look alike and sound alike is a big problem. And dosages, as I said, the overdosing is a problem more than underdosing in pediatric patient. So these are the care we take. These are the protocols we follow. So
Yeah, thank you so much. That's a very useful tips, I think, for us, especially for clinicians. Professor
yeah.
Atia, any comments to
Yes,
that?
so yes, similar, just to same thing to reiterate that it is the calculation that becomes an important part of it, and the dilution. So again, as she mentioned, that volume has to be low, and then understand that the required drug is diluted in that amount. So there are these calculation errors which are possible, and as she rightly said, two people doing and confirming is the best way. There is another issue with drugs, certain group of drugs where there is availability of certain formulations is not there. For example, we have antifungal agent isavuconazole. It is available as a syrup and a tablet, but in India, syrup is not available. Now, for a
Yeah.
child who will require much lower dose, if you take the tablet and try to break it and dilute it into the required concentration, it is a huge challenge because it will be such minute concentrations. Okay, as well as the tablet is an extended release preparation. That means you should not crush it, you should not powder it and redilute it. The kinetics of these drugs get actually impacted if we crush them. So there are too many nuances to pediatric drug dosing, and which many of these are formulation related. We have another antifungal drug called posaconazole, which is available as syrup and tablet. And we've seen, because we measure their blood levels, we see that the syrup is lesser bioavailable than the tablet. Okay, and uh, it's dosing with respect to food. So this antifungal posaconazole is better absorbed after food, whereas another antifungal voriconazole is absorbed better in empty stomach. And many times the nursing staff would do it the opposite way. So dosing, correct dosing, formulation, which has better kinetics. Now, for somebody who has to be given the drug through NG tube, and only tablet is available, you have to crush it, then we seek guidance from literature. We look at if any other people group has reported how to use that particular drug, in what dilution, what is the best way of diluting it or using that formulation. So like for posaconazole, although you cannot crush it, but if there is a way of diluting it where you allow it to rest and then give it after 10 minutes, where you feel that there is a homogeneous distribution of the drug. So availability of formulations and calculation of dose impact pharmacokinetics, and very critical for children, pediatric population.
Yeah, thank you, Prof. I think because of the time, we have to end this very fruitful discussion. I mean, like, I can see that from our discussion that the issue of pediatrics safety is actually very complex, but at least we are lucky we have you both in the field that we need more more study, I think, in this space. So, and also thank you for everyone who is posing the question. We hope that this discussion is valuable for you and you can bring more message, not just for your colleague, but also because I think in this Patient Safety Day, we aim to also increase awareness among patients, among caregivers, and also among our regulatory authorities. So we extend our thanks. Thank you to all speakers and all of you, and in making this World Patient Safety Day even possible, and focus on the theme safe care for every newborn and every child. We hope you continue sharing your experience and comments about ISoP 2025 patient safety on social media. And if you still have time, please join us for our upcoming presentation, which will come from the North America. So this is come from the Southern Hemisphere going to the North Hemisphere. And it will begin in a couple hours at UTC 1400 until 1600, or Eastern Standard Time from 10 to 12. And also don't forget to visit our ISoP online Facebook page or YouTube channel to view the recording of this webinar and other region webinars. And we will publish the records in the next few days. And of course, as a message, if you're not yet a member of ISoP, feel free to join us, because you will receive a lot of information, very useful information. Please join us this network, and we can exchange scientific and education innovations in pharmacovigilance to promote the safe use of medications. On behalf of ISoP, thank you so much for your participation and hope to see you in the next discussion. Thank you so much.
Thank you.
my dear ISoP family. Welcome to the ISoP Patient Safety Day 2025. If you don't know me, I am Angela Caro. I am the president of the International Society of Pharmacovigilance. And with a big team, we prepared this day just for you. Thank you so much for your presence here. We are very proud about the talks and all the speakers that are invited this year in this celebration. Every year, ISoP celebrates the Patient Safety Day for the awareness of people who is working in Patient Safety Day and for everyone who wants to participate in create a better world in hospitals and industry and every place that is in charge of patient safety. This year, we are talking about the children, and we want to invite you to think how to contribute in a better medication safety for them. Please go to the social networks of ISoP and please read about all the information that we have for Patient Safety Day. And additionally, listen the EMC podcast that we create just for talking about this important day. Thank you so much for being here, and please enjoy the talks.
morning, good afternoon, good evening, good night. Thanks to each of you for being here with us today to make this event possible. We trust that the meet sessions from the previous chapter have been of interest and have contributed meaningfully to your professional development. I am Professor Maxine Gossel-Williams from the University of the West Indies and Special Projects Coordinator for the North American chapter of ISoP. I bring greetings on behalf of ISoP. We are delighted to be hosting this session as part of Patient Safety Day activities in collaboration with the special interest group Pharmacovigilance in the Community. Since its inception in 2013, the NASOP chapter has strived to promote pharmacovigilance through educational and professional training initiatives and fostering partnerships with other organizations with similar interests. Our membership now stands at 226, who we regularly engage with monthly meetings. NASOP prides itself as a chapter that facilitates the engagement of all members through our working group initiatives and our annual meetings. One group of special mention is the American Pharmacovigilance and Pharmacoepidemiology Curriculum, AM2P group. Through this group, we now offer educational components specifically tailored for North America. Please visit the ISoP website for more information about our activities, including our annual meeting to be held December 3rd, 2025. I also invite all the attendees in this session to join our LinkedIn platform, where we share information on patient safety. The theme for the conference, Safe Care for Every Newborn and Every Child, is very timely. The presentations of day one were insightful in highlighting the urgent need to focus on risk minimizing interventions to protect this inadequately understood population, often inappropriately referred to as mini adults. Joining me is Rebecca Noss, a global expert in pharmacovigilance across both pre- and post-marketing contexts. With a strong medical foundation and 28 years of experience in the pharmaceutical sector, Rebecca holds an MSc in pharmacovigilance and pharmacoepidemiology from the University of Bordeaux and is an active member of ISoP. She also leads the special interest group Pharmacovigilance in the Community, which is dedicated to enhancing patient safety and reducing emergency room visits due to adverse drug reactions. This is achieved by educating pharmacists and healthcare providers on pharmacovigilance practices and empowering them to effectively guide patients in the safe use of their medication. Rebecca, thank you for joining us today, and I hand over to you.
Thank you so much, Maxine. I appreciate the opportunity to co-host with you. On behalf of ISoP, we are very pleased to welcome all of you to the 6th edition of the Patient Safety Day event that was held yesterday and then today, the 19th. The World Health Organization has designated September 17th as World Patient Safety Day to enhance public engagement in health, safety, and to promote global actions aimed at preventing and reducing harm associated with healthcare delivery. This year, the WHO chose Safe Care for Every Newborn and Every Child under the slogan Patient Safety from the Start, meaning this age group risks and harms that result from unsafe care. ISoP reaffirms the objectives of the WHO Global Patient Safety Challenge and calls on stakeholders and healthcare professionals to prioritize and take early action in critical areas associated with significant harm in pediatrics and neonatal patients due to unsafe medication practices. Starting, our president, Dr. Angela Caro, will address a few words to all of you, so please listen carefully.
Hi, my dear ISoP family. Welcome to the ISoP Patient Safety Day 2025. If you don't know me, I am Angela Caro. I am the president of the International Society of Pharmacovigilance. And with a big team, we prepared this day just for you. Thank you so much for your presence here. We are very proud about the talks and all the speakers that are invited this year in this celebration. Every year, ISoP celebrates the Patient Safety Day for the awareness of people who is working in Patient Safety Day and for everyone who wants to participate in create a better world in hospitals and industry and every place that is in charge of patient safety. This year, we are talking about the children, and we want to invite you to think how to contribute in a better medication safety for them. Please go to the social networks of ISoP and please read about all the information that we have for Patient Safety Day. And additionally, listen the EMC podcast that we create just for talking about this important day. Thank you so much for being here, and please enjoy the talks.
Alina is a specialist in pharmacovigilance and regulatory affairs with 18 years of experience in pharmaceuticals, including more than 10 years as a global consultant for marketing authorization holders, CROs, and distributors. Alina's work includes regulatory submissions and pharmacovigilance oversight in the Middle East, North Africa, South Africa, the European Union, Latin America, as well, and the Commonwealth of Independent States that cover both pre and post-marketing. Alina is a very experienced auditor in good practices, and her experience includes, again, the Middle East and North Africa, independent states, Latin America, and the European Union. We invite you to participate in this session actively. So please, if you have any questions, put them in the chat box and we will respond after we're done with the presentations. We welcome you, Alina. The floor is yours.
Thank you very much, Rebecca. Good morning, good evening, good afternoon, everyone. Thank you very much for joining today. For this, I can't say otherwise, a very important topic. And thank you very much, Rebecca, for your lovely introduction. So my topic today will be about introduction into pediatric pharmacovigilance and current gaps and challenges. So I'll begin with an introduction to pediatric pharmacovigilance and why children are aren't just small adults. Sorry, it's about me, but we can skip for sure. So I'll begin with the introduction to pediatric pharmacovigilance and why children aren't just small adults. Then we'll look at what makes pediatric safety unique, the main gaps and challenges, and some real-world examples, both failures and successes. So I'll finish by looking ahead and closing with a short summary. So now that we have set the agenda, let's begin with a simple question. What exactly do we mean by pharmacovigilance in children? And let me start with a boring but important definition. So pharmacovigilance is a science and a set of activities focused on monitoring, detecting, preventing adverse drug reactions in children. It is distinct from adults' pharmacovigilance because children differ in many ways. Their physiology, development, and behavior make their responses to medicine less predictable and sometimes very different. So that's why effective pediatric pharmacovigilance is so important. It ensures that the medicines we use for newborns, infants, children, adolescents are not just based on extrapolation from adult data, but supported by real evidence. So to really understand why pediatric pharmacovigilance matters today, we need to look back a little bit at the history. So in 1937, the sulfanilamide tragedy killed 107 people, most of them children, after a toxic solvent was used in a new liquid antibiotic. So this led to the Food, Drug, and Cosmetic Act of 1938, one of the first laws requiring proof of drug safety. A few decades later, unfortunately, we had another tragedy I'm sure most of you are aware of, the thalidomide disaster that caused thousands of birth defects, leading to stronger global safety laws and the foundation of modern pharmacovigilance. But there was also an unintended consequence. Children were excluded from most clinical trials and became therapeutic orphans. So many treatments for them were off-label with little safety or efficacy data. From the 1990s onwards, reforms began to change this. The US introduced the Best Pharmaceuticals for Children Act, and in Europe, the 2007 Pediatric Regulation made pediatric investigation plans, PIP, mandatory for new medicines. These steps created the framework that we use today. So now let's have a look why pediatric pharmacovigilance is so unique. Children, as I said, are not just small adults. Their bodies, their development, and even their psychology make them very different from adult patients. So physiologically, their organs are still developing, which changes how drugs are absorbed and cleared. Anatomically, their body's composition, more water, less fat, affects drug distribution. Cognitively, they might not be able to describe what they're feeling, so adverse reactions can be missed. And psychologically, children may resist treatment or stop it altogether, which adds another level of complexity of monitoring. So data shows us how important this is. For example, retrospective studies have found that children under 2 years old have the highest incidence of adverse drug reactions, up to 40%. And when we look at global pharmacovigilance databases like Vigibase, for example, between 2010 and 2019, there were more than 1,500 fatal adverse events reported in children, and most of them under 2 years of age. So now that we talked about why children need special attention, let's look at what pediatric pharmacovigilance actually does to keep them safe. Its purpose is to turn real-world experience into safer care. So first, we collect and analyze safety data specific to children, not just spontaneous reports, but also from trials, hospitals, records, registries, and the literature. We separate the age groups, newborns, infants, children, adolescents, because the same medicine can behave very different as the child grows. Second, we develop risk management strategy tailored to age. This can mean tools like weight-based dosing calculators, or maybe switching to child-friendly formulations. Third, we track age-related patterns of adverse events. Why? For example, in neonates, immature metabolism can cause toxicity. In toddlers, dosing errors and hypersensitivity are very common. In adolescents, adherence and CNS active drugs require special focus. So the aim is to spot risks early and act before harm spreads. And finally, pediatric PV supports regulatory decisions through pediatric investigation plans in Europe or written requests in the US. So let's take a look at how medicines are actually used in children today. First, off-label and unlicensed prescribing is still quite common in pediatrics. In some hospital settings, more than half of prescriptions fall into this category. To address this, we're seeing more use of age-appropriate formulations, liquids, dispersible tablets, or even mini tablets. This is great, but they are not always available. So when no pediatric form exists, adult tablets are often split or crushed to make smaller dose. This is risky because it can lead to inaccurate dosing, especially in the youngest and most vulnerable population. So care for children is also very multidisciplinary. Pediatricians are involved, pharmacists, nurses, caregivers, parents, and they all play a role in prescribing, preparing, administering, monitoring what's being taken. Each perspective helps reduce errors on the way. And finally, we have electronic health records now and adverse event reporting systems that are used more and more often. So while current practices show progress, there are still clear challenges that make pediatric pharmacovigilance especially demanding. So one major issue is the continued practice of breaking or crushing adult tablets with no pediatric form exist. This leads to inaccurate dosing and unpredictable exposure. So even when dosing is weight-based, small calculation errors can lead to big consequences. So recognizing ADRs is another challenge in young children, and I'm sure pretty much like in adults. Common symptoms like, I don't know, let's say fever or vomiting reflect the illness itself, or it can be drug-related, and it's hard to tell the difference. So we also face a serious lack of trial data, particularly for neonates and rare diseases. This makes dosing decisions difficult and often uncertain. Underreporting is still a problem, although with the raising awareness, it still exists. Children cannot always describe also what they feel, and caregivers or clinicians may not connect the symptoms to the medication. So hospital environments add another layer of risk. For example, a recent study in pediatric surgery found adverse event occurrence in about 1 in 4 patients, often due to drug-drug interaction. And across all these challenges, medication errors stands out. Prescribing or administration errors affect up to 15 to 20% of prescriptions and among the leading causes of ADR-related hospital admissions, also including children. So while medication errors are part of the broader challenge, they also contribute to safety concerns in pediatric population. Let's have a look at 3 real-life examples very quickly. So based on what I have presented so far, these real-world examples show how pediatric pharmacovigilance have made a shift, how evidence monitoring and smart interventions have improved outcome. For example, for HIV therapy in children in 1990, antiretrovirals were tested mainly in adults, and dosing was extrapolated to children, and often causing toxicity or poor results. With pediatric trials and safety monitoring, child-friendly syrups and dispersible tablets were developed, along with weight-based calculator, and that improved survival and quality of life for children with HIV. For vaccine, there is an interesting example of rotavirus. So early use raised concerns about interception, a rare bowel obstruction, and pharmacovigilance confirmed a small increased risk, only about 6 extra cases per 100,000 infants, but also showed the benefits that actually outweighed the risks. So together, rotavirus help prevent millions of hospitalizations and death. Another successful story comes from oncology with the drug imatinib. In this study, researchers built a physiologically based PK model for imatinib in children aged 2 to 18 years. They considered how the body matures, enzyme activity, body weight, and co-medication potentially. So the model showed the optimal dose for many children was about much lower per day than the dose simply scaled down from the adult dose. So it also highlighted that drug interactions affecting CYP3A4 enzyme could significantly change imatinib levels. So with this tailored dosing, imatinib was well tolerated, and toxicity was reduced, and children achieved good progression-free survival. My third example, final one, I'd like to shift focus from individual medicines to pharmacovigilance, to how pharmacovigilance works in practice as the system. So between 2021 and 2023, a study in Italy followed children receiving cancer treatment. Active pharmacovigilance team, which included pediatricians, pharmacists, nurses, of course, and pharmacologists, monitors the cases closely. So they found serious adverse reactions were almost 3.5 times higher, more common with off-label prescribing, and nearly 200 severe cases were detected, along with several near-miss errors. So the key result is that by working as a team, they could detect, report, and manage these reactions far more effectively. So as we look ahead, several priorities stand out for pediatric pharmacovigilance. We already see stronger use of real-world evidence, electronic healthcare records, registries to fill the gaps left by small clinical pediatric trials. AI and big data tools are starting to support early signal detection and help identify children most at risk. So this is still new, but pilot projects are rather promising. A more patient and caregiver-centric approach is also important, and I think it's getting more and more popular. We all talk about it. So involving families directly in reporting can make safety monitoring more complete and practical. And on regulatory side, I know there was a recent guideline, ICH 11A, which was finalized last year. This is a new global guideline that explains how and when data from adults or older children can be safely extrapolated to younger children. So the goal is to speed up access to medicines for kids while still collecting, enough safety data that we need, especially in vulnerable groups like children. Globally, of course, closer collaboration between regulators would be needed to close the gaps and avoid fragmented approaches. We also need more focus on special populations such as neonates and children with rare diseases, because there the data is still scarce. And finally, we must strengthen a culture of safe medicine use, not just in hospitals, but for example, in schools and homes. So simple things like accurate dosing, correct administration, altogether avoidance of unnecessary drugs can make a real difference in the everyday safety of children. So to conclude, I want to emphasize one simple but important message. Ensuring safe care for every newborn and every child is a responsibility we all share, regardless we are regulators, healthcare professionals, industries, or families. And we've seen how progress has been already made, but I'm sure there is still some work to do. So with this, thank you very much for your attention, and I'll now hand over to the next speakers.
Thank you so much, Alina. This was a fantastic topic. And again, the audience, please put your questions in the chat and we'll answer those after the presenters are finished. Now, let me introduce to you two speakers from the European Medicines Agency, Dr. Roberto De Lisa and Dr. Cosimo. Dr. Cosimo is a signal management lead at the European Medicines Agency and co-chair of the PRAC Smart Working Group, responsible for the review and testing of new tools for signal detection with a focus on pharmacovigilance in pregnancy and pediatrics. During the recent pandemic, he also coordinated the EMA's COVID-19 vaccine safety group. Dr. Roberto De Lisa holds a medical degree from the University of Cagliari in Sardinia and specializes in pediatrics medicines development, including clinical pharmacology and a master's in pharmacoeconomics. Since joining the European Medicines Agency in 2006 and the Pediatrics Office, Dr. Roberto has focused on the scientific assessment of potentially inappropriate prescribing and focusing on antivirals and migraine, as well as modeling and simulation, pediatrics, pharmacovigilance, and real-world evidence. Welcome. The floor is yours.
Thank you so much, Maxine. Thank you so much, Rebecca, for introducing us and for inviting us to speak about this important subject. You would see that many of the topics and many of the slides would actually partially overlap with some key concept that Alina already introduced us, and I thank her for a very comprehensive presentation. But I'm sure you would not mind, because those, in fact, are the key aspects that needs to be emphasized when conducting pediatric pharmacovigilance. I trust you can see the screen now. Can you see the slides?
Yes, we can.
Yes, that's very good.
Yes.
I will share this presentation with my colleague Cosimo, of course. So just a quick disclaimer to say that we are representing, of course, in this presentation our view, and this should not be taken as the view of the EMEA, intending as an institutional view. What is important and what is the population of children in the EU? Well, in many member states, unfortunately, it's concerning that the estimates for 2050, it's actually decreasing compared, the natality is decreasing compared to the previous year. But still, now nowadays, around 18% of the population in Europe is composed by pediatric patients. When we talk about pediatric age group, so of course, we talk about a universe on its own. So we're talking about newborns from birth to 1 month, and we will see also that there's the issue about preterm newborns that actually are actively treated in intensive care units who also experience adverse drug reactions. Then we have infants from 1 month to 2 years that are susceptible to adverse drug reaction due to immaturity of some of the metabolism systems. Then we have children from 2 to 12 years of age that they also have need for those adjustments, and adolescents that, although for some aspects can be assimilated to adults, they have all their own specificity and susceptibility to different adverse drug reaction. First of all, the problem with pharmacovigilance and for safe use in pediatrics has always been the dose, but recently this problem has been more or less overcome with new indication and new studies that have targeted the pediatric population. We have touched upon also in the previous presentation about the adverse reaction that affect children across different environments. Especially, of course, hospital admissions. Adverse drug reaction can be a cause of hospital admission. So a reaction to a drug must always be kept in mind when there is something that is not explained and is not justified by another diagnosis. Then we have reactions that are actually happening during the hospital stay of children, so in hospitalized children, which prolong the burden of the hospitalization and sometimes the timing the children are spending in hospital. We will see in this case sometimes hypersensitivity reaction are responsible for a lot of this. Then, of course, reactions in the community settings, and in the general population, we can say that the literature is a little bit newer and fresher compared to adults, but we can say that the range is from 1 to 9%. So the first thing to do in pediatric pharmacovigilance, but also in adult pharmacovigilance, is to know, then to recognize, and also to share this information. How do we grow our knowledge about the safety profile of a medicine in pediatric population? Well, you know, and it has been highlighted before, in the US and in EU, we have specific law enforcement measures to agree what is going to be the pediatric development of a medicine before it reaches the market. In Europe, this is contained in the so-called pediatric investigation plan. Importantly, in this plan, we have plans to conduct non-clinical studies that involve juvenile animals in a way, so adding knowledge on the ontogeny of the medicine. Then we have the study and the mandatory requirement to have an age-appropriate formulation development, and this itself has also diminished improved safety, diminished adverse reaction and improved safety in children. Then we also have in the pediatric investigation plan the list of all the studies. Once this pediatric investigation plan is completed, of course, we have a basis to arrive at the marketing authorization. That, of course, for some pediatric diseases, you know, it cannot come soon enough because, fortunately, the pediatric population is an healthy one, but still there are many diseases that are congenital or hereditary. We have a severe cancer that can undermine, of course, the life expectancy, and we have other diseases that are rather orphan that manifest in the pediatric population. So we arrive at the marketing authorization, but the story, of course, doesn't finish there. There are specific measures that needs to be in place, as well as in adults, to ensure that use is safer. I will give the floor for this slide, particularly to Cosimo, because he can give you an insight of what we know at the time of the authorization and what is it that we don't know. Cosimo?
Yes, thank you, Roberto. And indeed, this is a slide just to represent what we already mentioned. It was already mentioned by you and by Alina, that the incidence and the prevalence in real-world settings are critical, as they determine how likely it is to actually observe an adverse event. Now, this is what is essential for us in pharmacovigilance because that is what drives our monitoring strategy. So at the time of the authorization, clinical trials, the gold standards, of course, they give us a very robust evidence on the efficacy, on the quality, and on the safety, on the most common adverse drug reactions. However, gaps remain for patients with which have special condition or they're actually excluded from the trials. So we often do not know the long-term effects, the drug-drug interaction already mentioned, the off-label use, medication error, but most importantly, and that's what illustrates the little table on the right-hand side, is that to be able to capture or detect the rare and very rare event, this is very challenging, and we need post-marketing data. In fact, to reduce the chance of missing a very rare events to only 5%, we would need data from about 30,000 patients. And if the trial only includes 500 patients, as it always happens, particularly in a rare disease, the chance of missing a rare event rises to 95%. So as you can understand, yes, the clinical trials are very fundamental for the establishment of the safety of a medicinal product, but the post-marketing data will be essential for the establishment of the full safety profile. Over to you.
Thanks, Cosimo. Let's go back a little bit before we go back. We go and see what is done in the post-authorization phase. How this has been developed in Europe. We said like we had the pediatric regulations of specific law to have a dedicated development in pediatric patients, but already at the time in 2007 there was a concept that the pharmacovigilance was also to be conducted for the pediatric population with some special attention. Then also Alina mentioned the reflection paper on the user extrapolation in medicine development that throw the basis also on what we can understand from adult data and which kind of data can inform the use in pediatric patients, until we have in 2018 we have adopted a special guideline for the conduct of pharmacovigilance in the pediatric population. Now, the measures that are included there, they are not radically different from those from adults, but there are some specificities and some specific aspects that are highlighted there. Another aspect that I wanted to draw your attention to is that since 2013, we have seen, and I thank my colleague Kateri Zhang for this research, Stephanie Zhang for this research. Since 2013, we have seen a massive growth of all the pediatric indications in the EU. This means that all the pharmacovigilance activities are going to be multiplied, and there will be more and more pediatric medicines on which to do signal detection, on which to do safety authorization studies, or to examine and assess what are they call the pediatric safety, the post-authorization safety reports. As I said, the pediatric pharmacovigilance guideline has some aspect that concern like the age-specific monitoring, on which Cosimo will spend some slide to give you an idea of what we do in-house on those reports that arrive to that are a signal to the European Medicines Agency. There are some consideration for off-label use and unlicensed drug use. There are some consideration for active surveillance on the design of post-authorization studies that are effective for children. There are also some consideration regarding formulation challenges and excipients, and how to take this into account in the assessment in pharmacovigilance, and particularly also which kind of medicines and for which effects long-term monitoring is effectively needed, because there is a delayed risk of adverse drug reactions. Pediatric off-label use is extremely common, especially for medication that have been authorized long ago. But of course, is not a bad thing on itself, but we have to recognize that it can be linked to a risk of increased adverse drug reaction. Why? Because we don't know sometimes entirely the profile, although for these medicines that have been authorized in the past, the amount of knowledge now is quite substantial. Because there could be dosing errors, because generally for these medicines, they did not have a specific or studied, they didn't study the exact dose to be dosed in children, but were derived from adults. Although here I will open like some additional consideration saying that use the modeling and simulation now is helping us also in resolving this. And I will go also to stress the fact that the pediatric development plans, and it's a concept that Alina already introduced, the pediatric pharmacovigilance is more like a circle of knowledge, like where we start with the developments, then with this development puts the basis for an effective risk minimization plan. Once the medicine is used, is on the market, we have the post-authorization safety reports that inform us on how the use is going in, what are the use, what is the uptake, what is the utilization, and what could be the suspected safety signals that are connected to the use in pediatric population. For pediatric patients, for example, in the RMP, we listed some concerns that need to be taken into account, particularly in development. So effect, of course, any drug that has an effect on growth, on bones, on sexual or neurobehavioral development needs to be studied specifically. And these aspects need to be particularly elucidated during development with appropriate evaluation. For neonates and toddlers, again, we need to have particular monitoring and the preambles to have a safe use given the immaturity of some systems. And again, the excipients are thoroughly evaluated when a formulation is proposed based on precedents to ensure that they are safe and they are not concerning for use in pediatrics. We have, for example, at the European Medicines, a formulation expert group that revises all the formulations that are proposed, not only to see that they are like, that there is no waste of medicines, that the doses minimize the risk of any errors, but also that the excipients are the most appropriate ones. Alina also touched upon Rotarix, and I'm happy for that because it was an important achievement of pediatric pharmacovigilance. And nowadays, based on results of very significant studies, we have ensured the safer use, and especially we have on the market safer product to decrease the risk of infection by rotavirus. That I would remember in some countries is a case of morbidity that is very, very high, with diarrhea that can even have a fatal outcome in some settings. More recently, during the pandemic, there was another topic that was really prominent in the media. For example, tocilizumab, the Comirnaty vaccine. There was supposed to be an increase in risk of myocarditis. Now the EMA has launched a study that is currently ongoing, has provided some interim results. But again, just to say that how pharmacovigilance has evolved and how tailored studies are conducted in the pediatric population. There is a group also of the International Neonatal Consortium that are now focusing on specific tools to standardize the assessment of severity in the neonatal setting. In the neonatal setting, and because of course the neonates they cannot express sometimes what is the adverse effect for that is where they are involved. So they either sleep more, they eat less, they cry. But in this way, we can standardize and we can have a more homogeneous reporting of any reaction that is also recorded in the neonatal setting. Other emerging topics, also Alina mentioned the role of real-world evidence is also a tool that we are using more and more at the European Medicine Agency, the role of precision medicine, and the issue of communication, because communication of safe use in the pediatric population is a topic on its own. You know, we need to address specifically the communication need, for example, of adolescents. We need to involve children in the understanding of the medicines that they are taken and possibility that they have to understand what it could be an adverse reaction. We need to involve the carers and the parents also in this framework. And with this, I will give the floor to Cosimo that will tell you more about collection and correct identification of signals.
Thank you, Roberto. And indeed, after your overview of all the activities focused on pediatrics, and the prominent, let's say, in terms of detecting new safety concern is the monitoring of post-marketing data. And this is, of course, essential because it is actually collected, it's reported by both the healthcare professional and the patients and themselves to the national competent authorities or the marketing authorization holders. At that level already, we often talked about underreporting, however, in pediatrics. However, we should also talk about the quality of reporting, because most of the signal could be already identified based on the available information in good report, which is expressing specific details and metrics for the establishing causal link between a drug and an event. So at that level already, because the process is already well, let's say, guided through the specific GVP and specific reporting rules, some details on the quality of the reports could be facilitated, that we hope in the future, even with processing using also AI and collection of data at different levels. Now, another thing that we need to say is that we receive this large amount of information, not only for pediatrics, into the Eutrovigilance system, which is the European system for collecting, managing, and analyzing adverse drug reactions. And we screen them all based on priorities, but we screen them at the level of a drug and on the event. However, without a specific stratification by age and characteristic of the patients, we wouldn't be able to be focused on detect signals in pediatrics. Next slide, please, Roberto. So this stratification is at the level of the ICH, and nonetheless, we are able to identify specific subgroup within the total population. As I mentioned, there are specific priorities we apply based on the likelihood that the reactions is linked or potentially linked to drug use, based on the mechanism of actions, on the previous knowledge of the drug itself. So during the screening of spontaneous data, the intensive screening is across all age groups, and this is for designated medical events. However, for more common events that are like multifactorial in etiology or maybe confounded by the disease itself, we rely more or mostly on the statistics, in particular on the frequency of reporting. And as far as the pediatrics are concerned, we try to ascertain an imbalance between pediatrics and the rest of the population. And of course, we also monitor the literature in order on a weekly basis. That is just to ensure that our understanding of the drug safety profile continues to evolve in real time. So next slide, please. And this is more focused on the special population, special situation. If you could move to the next slide, Roberto, please. Yeah, I think there is. I think it's animation. Yeah, we move on. We didn't.
Okay.
Yeah, we go. I think you need to go for the full slide. Sorry, these were not removed previously. Yes, so this is a very short. No, go backwards now. I mean, we don't need the slide neither. It's just to say previously what we focus on the terms that are likely to be related in pediatrics, and this list of targeted medical events in pediatrics is really focused on some outcomes or reactions actually that could easily link to a very serious or fatal outcome in pediatrics. So we actually rank them and we closely monitor because we know they are more frequently reported with this serious outcome. While on the statistics side, we rely on reporting of thresholds. And as I said, we have specific thresholds to take into account the underreporting in pediatrics, but also difference in frequency between adults, elderly, and pediatrics. Next slide, please. So now moving to a specific focus or topic where actually this is the general trend where we monitor a specific drug, but when we move to specific contexts such as pandemics or vaccination, then we need to take into account additional tools, additional methodology, and the observed to expected analysis actually what we use for enhancing the monitoring strategy. Here is basically a comparison between the cases that we observe spontaneously, and we compare them with the cases we would expect based on the background incident rate and the exposure data of the vaccines within a specific risk windows. Now, if there is an imbalance, then we try to contextualize the data based on, we try to match the case definition, we compare with the electronic records, as I said, with the coverage data when available in a specific risk window. But this wouldn't be sufficient, yet again, if we couldn't have all the information at the level of the age and gender subgroups. So we need to stratify each of these data, observe the expected, the background incidence rate, and the coverage at the level of each age group in order to differentiate the imbalance and understand the excess risk in these populations. Next slide, please. And we are nearly there. Next click. So here is just to show how dashboarding also are taken into account or built whenever we need to have a strategy to monitor data over time. And now they allow us to visualize how cases are distributed in pediatrics versus the whole population. And we also track how the risk is changing over time if we implement some sort of risk minimization measure. And we want to, or we expect that there is a reduction of the number of cases received. Next slide, please. Yes, I wanted also to flag a few cases, a few signals that have been triggered using spontaneous reports. And I'd like to start with the levetiracetam, the dosing error in children. This was a specific signal which we traced down to the dispensing mistakes and the incorrect use of syringes. And this actually was causing overdose in children because of the misplaced or the misuse of the syringes. And this has led them to actually perform readability studies for the parents and a revision of the product information, both improving the color codes of the packaging, but also using for the first time pictograms to identify different age groups. And that would be actually a risk minimization measure to reduce the risk of dispensing mistakes. Another important example is the fentanyl patches, transdermal patches, which led to accidental exposure in children, signals initially detected by FDA, because it was traced down basically to the root cause was either the poor disposal of the patches or even a patch transfers from parents to children, and actually tragically led to some fatal cases. This has prompted actually stronger visibility measure for the patches themselves to avoid this issue. And last but not least, but it's what already Roberto mentioned, is the very popular signal with myocarditis and pericarditis. This, I mention it here just to say that we could identify the signal based on the observed to expected analysis. However, it takes more real-world data evidence or epidemiological studies that came later to measure the excess risk in this population in young men at that time. And actually, with the ongoing studies, we try to elucidate even more the mechanism of actions and reduce the risk as much as possible. Now, moving on to my conclusion, I would just say in the last slide that yes, so we try to collect as much as possible the available evidence. Sometimes we need to generate rapid evidence, as I explained during mass vaccination, but we always keep the focus to children and to the different subgroup population, not only children, but the vulnerable. And the pharmacovigilance techniques will change according to the age group because of their peculiarities. Pregnancy is another one, and breastfeeding and even more. So I would say that clinical trials are very important, and particularly in children and perhaps also in pregnancy in the future. Or there are some studies occurring in pregnancy, and the correct data stratification is essential for actually stratify the risk and characterize it. I would say also I should mention here that AI will play an important role in addressing unique challenges to children and in general to the vulnerable population, as not only improving the quality of report, but also fast identification of specific trend in specific groups, so that we can ensure safe treatment, especially for the most vulnerable. And that's a very good example where we keep monitoring, and that's what transforms data into public health protections. And I'll stop here for any question. Thank you very much for your attention.
Thank you so much, Dr. Cosimo and Roberto. It was excellent. Excellent. Now I would like to introduce Dr. Siva. He's going to join you guys as part of the panelists. And then we'll go over a couple questions and then see if the audience, posted any in the chat box. Dr. Siva is a physician and he works as a global safety director at a large pharmaceutical company, has extensive experience in AI, in safety automation, signal and risk management, and end-to-end PV operations. So I'll go ahead and start with the questions. So if you don't mind, Alina, you'll be first. In pediatric pharmacovigilance, we often talk about neonates, infants, and children and adolescents. From your perspective, which of these groups presents the most unique safety challenges?
That's a good question. I would say if we talk about different groups, so the toddlers, of course, they are growing kids, and everything is changing very quickly for them. So they will be challenging. They refuse to take medicine sometimes, but it's manageable. For adolescents, it's it was mentioned in the previous presentation. It was they are more or less closer to adults, but I think for the infants, for the newborns, this is very, very challenging population. So they have immature organs, they have rapid changes, they have limited communication, of course, and tiny sample size. And if we go even further and talk about premature babies, I worked in one of clinical trials with premature babies. They even add the complication of actually additional conditions, like, let's say, respiratory challenges. So I think we should focus, not focus, but I think for me, the most challenging populations are infants and premature babies.
Agree. Thank you. Thank you so much. Now, Drs. Cosimo and Roberto, I have a few questions for you. How are the regulators strengthening pediatric pharmacovigilance policies? And are there any mandates for age-specific post-marketing surveillance?
Okay, maybe I can have a go and then Cosimo can complement. So at the moment, we treat every medication on its own. So if the medication has a pediatric indication, we would consider what are the risk minimization measures, for example, that are needed, or if the reaction that we are observing is specifically generated in pediatric patients, we will assess this in this population. At the moment, the approach, except for what Cosimo has presented, so in signal detection, the approach that we take is the same. And then, I mean, the pharmacovigilance is conducted in the same way. What is differs, for example, is like, for example, when something is authorized, for example, an antibiotic recently has been authorized from 3 months of age. Of course, we request that in the periodic safety update report, there is a special focus on safety, and this is not need to be done for 2 to 5 years. So, because we are conscious that, of course, the number of patients that have been recruited in that trial was relatively small, and maybe that antibiotic has a longer life. So this is only an example, but generally we tailor-made the recommendation for safety measures, either post-authorization safety studies or additional studies, to what is the evidence at the moment of the authorization and what are the characteristics of the medicine.
Thank you. Okay. How about what role can caregivers and patient communities play in enhancing pediatric safety reporting?
Cosimo?
Yeah, as I said, I think, I'll go for this. I think, quality of report plays an important role because we would try to be more as detailed as possible. Now we're talking about pediatrics, but for instance, in pregnancy, it would be trivia to have, information about the gestational period, for instance, and then you recognize patterns and so on and so forth. Equally, neonates, we have a very small window intervention when it comes to the younger age group, because of course, the outcome it's much more severe most of the time. And I think what will help in general is that communication, and I see a text also in the chat, communication is also crucial because we need to be able, hopefully with the help of electronic records and the big data, we need to be able to measure the risk and reassure, because sometimes the fear is higher compared to the risk and the disease we are treating. So that is fundamental. And going forward, as I said, advanced technology, trying to screen as fast as possible literature, but also we are trying to use NLP, natural language process, to read quickly, just a hint where we need to focus for valid cases. This will create, as I said, fast generation of evidence. But we need to validate such systems, so we need to see how they're going to help us in improving the quality of reporting as well.
Thank you. Let me check the chat box. Okay, you answered that one. Here's another one in the chat. How do differences in reporting requirements across countries affect risk traceability and share regional contexts?
That is a very good one. I might take that too as well, because of course there are reporting requirements, and we notice heterogeneity, we notice variability, and then you need to take into account when you're using a global database such as VGBase or such as our database, Hydra Vigilance. We try to focus now on subgroup analysis also at regional level, so that we can see that difference in frequency, difference or the analysis are actually supported. For instance, we noticed that there are certain events, they follow the regional trend, and they're not confirmed in all the regions. And we need to take that into account. And also, I would say that we actually, that is what, real world data will help us based on the drug utilization within a specific region, and the type of population will help later on to confirm the initial signals that are triggered through spontaneous reporting.
Right, I see. Okay. And regarding pediatric safety guidelines, can EMA allow external pharmacovigilance experts to be part of the public review and then provide the feedback?
Yeah, so basically, as I said, the good pharmacovigilance practice for the pediatric population was agreed a few years ago. Now we have matured considerable experience, I would say, But the experience that we have matured does not really nowadays point out to a different way to conduct pharmacovigilance for adults, between adults and pediatric patients, although there is a need to do a thorough review. We are currently conducting such review, and in the future, probably the GVP would, so the guideline would need updating, and generally when the time comes, we either organize a workshop to gain consensus also with the opinion leader, but in any case, at the very minimum, the guideline is released for public consultation, and at least then all the organizations that we deal with, patients organization, healthcare professional organization, are generally sent a reminder of the guidelines that are under consultation, for which we include comments. If I can, maybe one of the aspects to be taken into account is not only the conduct of the pharmacovigilance, but is the impact of the risk minimization that we put there. So once we recommend the communication, is it impacting adults and adolescents in the same way, for example, for medicines that they use? Or if we restrict the marketing authorization of a medicine, or worse, we withdraw from the market, what's going to happen for a pediatric population if there are lesser alternatives that are authorized compared to adults? On this particularly, I think we need further experience and further consideration. Thank you.
Great, thank you so much. Okay, Dr. Siva, welcome. From your perspective as a physician and safety expert, what unique challenges exist in detecting and managing adverse drug reactions in children compared to adults?
Firstly, thanks a lot for inviting me to speak on this, and wonderful presentations by all the speakers that spoke before the panel. A great question again, right? I think there are multiple challenges because children are not to be treated as small adults. Some of the unique challenges that are there are basically the physiology, the developmental pharmacology are completely different. They see a rapid changes in the ADME, which is the absorption, distribution, metabolism, and excretion across the neonates to the infants, to toddlers, to adults, which means that the risk windows as well as the dose-response relationships vary. And the other challenge is also because the pediatric population dosing errors, right? Because we have to provide them calculations of the doses required based on the weight as well as the age. So that itself is a unique challenge. But at the same time, as in one of the presenters that I also presented, right? So there are underreporting, there is reporting bias. We do not have a lot of denominators, especially for the rare events. Definitely the formulation risks itself is a change. It's a challenge when we compare it with the adult population.
Thank you. Next question for you, Dr. Siva. This is regarding technology, which is transforming healthcare. What role do you see AI or digital tools playing in improving pediatric safety, especially in adverse event reporting and data interpretation?
Well, again, there are multiple frameworks to include pediatric populations in the trials, and indeed the pediatric investigation plans, and all of them. But still, there is a requirement in the industry that you can leverage some of the HRs, the RWD data, to even identify some of these early signals, right? So we can also have self-controlled case studies, which is very well proven in the vaccine, but we can also evaluate the same in this area. But at the same time, I think there needs to be a smart dosing calculators that we most of the times have handy the hospitals, right? The variables, some of the reporting apps for the caregivers is also a very, very crucial technology that we need to leverage, especially in the pediatric practice.
Thank you. In your experience, what kind of collaboration between pediatricians, caregivers, and safety professionals can make the most impact on child safety, especially in low resource or overburdened healthcare settings?
Well, I think that's a great question because we work in a SIG, which is very much doing the focus of having the SIG is definitely this, right? How do we really bring in all the collaborators, the pediatricians, the caregivers, and as well as ourselves, the safety professionals, right? I think there are multiple ways in which we can really low, lower down the burden from these low resource settings. One is definitely to see how do we train the community health workers and make them more engaging to this, right? On some of the areas, data capturing, how do they have to escalate things to the clinicians at right time, right? And also build certain forms which are, very much bilingual sometimes, most of the time, because caregivers have the ability to read and write as well. So that gives them a lot of leverage. At the same time, I think how do we really embed the safety into routine child health contacts is an important aspect. And this we have been seeing in the immunization visits, the growth monitoring when we have a pediatric case in the OPDs, right? We can also look into follow-ups, right? I think joint education from both caregivers as well as clinician is very, very important. But having implementing all of these, we need to also have certain feedback loops, right? Where they acknowledge the caregivers report, they can acknowledge and also have simple guidance. When the clinicians report, safety teams should provide that case level feedback. And that's a collaboration, right, to even enhance this. But from a low-tech digital enablement, we need to see how can we use some of the applications that are there in the mobile, right? WhatsApp groups, right, or a Twitter group, right? I think these are some of the things that we can definitely leverage at least in the low resource setting setup to increase that collaboration between all these different parties. But as I said, children are not small adults. Detecting, managing the pediatric ADRs require a tailored epidemiology as well as very much child-centric data capture. They very much require those safety checks. The caregivers play a very important role in this, right? And definitely artificial intelligence and the tools that are available are readily in our hands, tip of our hands, are very, very crucial to even provide that support.
Thank you. You brought up an important point. This is why we have pharmacovigilance in the community is, we got to teach, train healthcare providers and not just the healthcare providers, but also, the patients, including the caregivers. Excellent. Thank you. And one final question. This is addressed to all of you. What is one actionable item each stakeholder can do this year to ensure safer care for children?
Maybe I can start on that because, Rebecca, I think you mentioned it just now. So we all understand how busy healthcare professionals are, but nevertheless, I think raise further awareness for, about the reporting tools for patients and caregivers is very, very important. I can specify that it's basically the most important thing to raise the amount of reporting. Then I think from the regulator's perspective, I think also Siva touched on it a little bit, that it will be great to see not just collection of data, but maybe collaboration and maybe sharing of this data so that we can see all this data together from clinical trials, I don't know, from registries, from hospitals, you name it. And then if I'm thinking from perspective of the industry employee, I would say that I've seen quite a few pediatric so PEEP programs, which is quite reassuring. And yeah, I think my message would be just to kind of not just collect the data, but make sure it's detailed, it's full, and it's connected and usable.
Right.
No, I think I completely echo the thoughts of Elena. And the other aspect is the pediatric population's over reliance on adults make them more vulnerable, right? And as a caregiver or as a parent, right, we need to ensure that we report any unusual change in behavior, or maybe appetite sometimes, or sometimes sleep as well. So these things most of the times are not considered to be very serious, but I think we need to ensure that these are looked from a broader lens, even if we are unsure if it is drug related or not, right? Because children might not be in a state of expressing their symptoms very accurately. And I would say the best pediatrician is the mother or the caregiver or the parent at home who can really understand and correlate between those unusual changes with what has happened.
Yeah, everything matters. Even the little input go a long way. That's true.
Correct.
100%. Great. Anything, Dr. Cosimo and Roberto, you would like to add?
Actionable item, I would say something that is pretty obvious and quite simple. For the prescribers, please read accurately the summary of the drug characteristics that is available online, fetch it, print a copy, save a PDF copy on your mobile, and read at the very least the safety part and the warning side and the contraindication as well, the drug interaction. And for patients also, you know, there are patients leaflet. Every time a new medicine is taken, please read it carefully. I'm not talking about paracetamol clearly, but I'm talking about the crizotinib, you know, blinatumomab. These are all new pathways, new medicines that are completely, in a way, that are new for the pediatric population, and are also new sometimes for the pediatrician that would not necessarily have been familiar with them. So yeah, get familiar, know the safety profile, so in a way that you can detect what is unexpected. Sorry, Cosimo, you were meant to.
Oh, no, I think you nailed it, because that is very important. We put a lot of effort, a lot of work into try to minimize the risk. We would like not only to recognize, identify new risks, but we would like to diagnose them as fast as possible, manage them as good as possible, and also, of course, prevent them. And I would also add to Alina's comment, which I fully support. We need data. We need also quality, as I mentioned a few times. We are coming into the era of pharmacogenomics, and so we can really make a difference if we try to characterize the risk as much as possible in line with the target population. Thank you.
Excellent. Thank you. Maxine, you have a question?
Yes, thank you, Rebecca. I enjoyed all the presentations. I really learned a lot as a basic pharmacologist. I really enjoyed the presentations. I liked one of the slides that a comment about off-label use and balancing with benefits versus risk. And I think that's a very important point to keep highlighting, especially with all of what's happening with this push for pediatric population in clinical trials. I just see the price of drugs moving up even more for our low and middle income countries. So my comment to you, I just wondered, where is SIAMS in all of this? If any of you know, if they are, you know, looking at some working group, you know, to give some standard operating procedures with all of this push of in, you know, the importance as it relates to managing the safety risks that we are engaged in right now with drugs and pediatric population.
No, I'm not particularly aware of any initiatives in this sense. Thank you.
Okay.
Me either.
So is it that SIAMS is fast asleep? Usually they would have a working group moving along to provide some guidance to us. You know, we depend on their guidance quite a bit. Okay, that's it for me, Rebecca. I guess I will have to probe some more in terms of SIOMs where they are.
That's a great point. Yes, definitely. I'm looking in the chat box. I don't see any new questions unless Zaira, any questions that we're not aware of? Okay. No. Well, thank you so much. It was excellent. I learned a lot. I'm always learning. Thank you so much for your time. I know all of you guys are busy, so we greatly appreciate it.
Thank you very much.
Thank you very much. Thank you.
Thank you all for the attention.
Thanks.
Thank you.
Thank
Thanks,
you.
bye.
Thank you very much. Bye.
Muchísimas gracias por esta invitación.
Buenos días, buenas tardes a todos. Bienvenidos a este segundo día de actividades del Día de la Seguridad del Paciente de la Sociedad Internacional de Farmacovigilancia ISoP. Como presidenta del capítulo latinoamericano, la verdad es que me complace en estar el día de hoy con todos ustedes. Gracias a todos por estar unidos en esta transmisión, la cual pues se ha dedicado con mucho esfuerzo para que el mensaje sobre seguridad del paciente desde el inicio de la vida, para nuestros niños, para nuestros neonatos, llegue a todos y cada uno de los rincones del mundo. Gracias a todos ustedes porque es posible que con su conexión, con su seguimiento se dé este evento posible. Confiamos en que las charlas de estos capítulos, no solo el de hoy, sino que los anteriores hayan sido de su interés y que contribuyan significativamente a su desarrollo profesional. Como les mencioné, yo soy Liliana Vargas, presidenta del capítulo latinoamericano de ISoP, pero además tengo el rol de jefa del Departamento de Investigación Farmacoepidemiológica en el Hospital Infantil de México Federico Gómez. Entonces ya se imaginarán que pues con más ahínco hago énfasis en que tengamos el Día de la Seguridad del Paciente como un día de visibilidad para todos los profesionales de la salud. Asimismo, soy profesora de asignatura de la Facultad de Química de la Universidad Nacional Autónoma de México. Es un honor para mí ser la encargada de conducir estas sesiones para la región de Latinoamérica de este año. Por lo que, a nombre de la Asociación Internacional de Farmacovigilancia ISoP, estamos muy emocionados de darles la bienvenida a todos y cada uno de ustedes a esta sexta edición del evento de ISoP Patient Safety Day, que se lleva a cabo el día de hoy y el día de ayer, ¿no? Esto con motivo justamente de que la Organización Mundial de la Salud estableció dedicar el 17 de septiembre como el Día de la Seguridad del Paciente para incrementar la participación pública en la seguridad sanitaria y promover acciones globales para prevenir y reducir los daños relacionados con los cuidados de la salud. Este año, la OMS propone el tema Cuidados seguros para todos los recién nacidos y todos los niños. Bajo el lema La seguridad del paciente desde el comienzo, para poner de relieve la vulnerabilidad de este grupo etario frente a los riesgos y daños derivados de una atención insegura. ISoP reafirma los objetivos del Reto Global de la Seguridad del Paciente de la OMS y hace un llamado a los proveedores y profesionales de la salud para priorizar y tomar acciones tempranas en áreas críticas asociadas a daños significativos en los pacientes pediátricos y neonatos debido a prácticas de medicación inseguras. Estas incluyen medicamentos de alto riesgo, medicamentos LASA, que son los que se parecen o suenan semejante, las conversiones de dosis o los cálculos de dosis, las transiciones en la atención hospitalaria, la polifarmacia, las reacciones adversas a medicamentos, la automedicación no informada y las disrupciones de importancia en la provisión de servicios de salud. Antes de comenzar con las ponencias, escuchemos atentamente a nuestra presidenta, la doctora Ángela Caro, quien les dará algunas palabras.
Hi, my dear ISoP family. Welcome to the ISoP Patient Safety Day 2025. If you don't know me, I am Ángela Caro. I am the president of the International Society of Pharmacovigilance. And with a big team, we prepared this day just for you. Thank you so much for your presence here. We are very proud about the talks and all the speakers that are invited this year in this celebration. Every year, ISoP celebrates the Patient Safety Day for the awareness of people who is working in Patient Safety Day and for everyone who wants to participate in create a better world in hospitals and industry and every place that is in charge of patient safety. This year, we are talking about the children, and we want to invite you to think how to contribute in a better medication safety for them. Please go to the social networks of ISoP and please read about all the information that we have for Patient Safety Day. And additionally, listen the EMC podcast that we create just for talking about this important day. Thank you so much for being here, and please enjoy the talks.
Gracias por su atención. Un mensaje muy bonito por parte de nuestra presidenta Ángela Caro. Este evento también se construye con sus voces, por lo que los invitamos a sumarse a la conversación en redes sociales, compartiendo sus impresiones del evento con los siguientes hashtags: el ISoP PSD 2025, World Patient Safety Day 2025, las iniciales del 2025, ISoP Online, Pediatric Safety, Children's Safe Care, and No Harm from Birth. Todos estos hashtags nos ayudan también a visibilizar un poco más acerca de este día tan importante. Ahora permítame presentarles a nuestra primera ponente, la doctora Mara Medeiros, que presentará su conferencia titulada Atención segura para todos los recién nacidos y todos los niños. La doctora Mara es directora de investigación en el Hospital Infantil de México Federico Gómez. Además, ella es pediatra nefróloga y tiene un doctorado en ciencias biomédicas. Además de eso, pues ha sido profesora en la Facultad de Medicina de la Universidad Nacional Autónoma de México y actualmente es miembro del Sistema Nacional de Investigadores Nivel 3 en México. Entonces le damos la más cordial bienvenida a la doctora Mara.
Muchísimas gracias por esta invitación para compartir mi experiencia con este tema de atención segura para todos los recién nacidos y todos los niños. En los próximos minutos les voy a hablar brevemente de las edades pediátricas, del uso de los medicamentos en pediatría, de la farmacocinética y los determinantes de dosis-respuesta, de la ontogenia de las diversas funciones corporales que influyen en la farmacocinética y de las consideraciones que hay que hacer para el ajuste de dosis. Según el Nelson, el Tratado de Pediatría, la edad pediátrica va desde el recién nacido hasta los 18 años. Pero, por ejemplo, los NIH de Estados Unidos lo consideran hasta los 21 años de edad. Estas edades pediátricas a su vez se subdividen en diferentes periodos. Los recién nacidos son del nacimiento hasta los 28 días, los lactantes los primeros 2 años de vida, los preescolares de los 2 a los 5 años, los escolares de los 6 a los 12, los adolescentes de los 13 a los 18. Aquí en esto de la adolescencia puede variar un poquito según la definición. Hay quien los considera a partir de los 10 años, pero bueno, a grandes rasgos es así como se consideran. Y es importante mencionar que los recién nacidos a su vez se pueden subcatalogar en si son prematuros, de término o postérmino. Y es importante considerar esto de las edades pediátricas porque los niños tienen 2 grandes momentos de crecimiento. Uno de ellos son los primeros 2 años y justo la edad de la adolescencia, ¿no? El crecimiento se da un poco más rápido en las mujeres, más temprano en las mujeres, que es la línea punteada, y en los varones es la línea sólida, pero es el segundo brote rápido de crecimiento. Entonces, en el gráfico de la derecha, en la línea verde tenemos el crecimiento general, pero podemos ver que el crecimiento del tejido nervioso contrasta con el crecimiento del tejido genital. Y el tejido linfoide crece muchísimo en los años de los primeros años de vida y después involuciona hasta alcanzar el valor que tiene en el adulto. Y eso influye mucho en la presentación antigénica, en la reacción de la respuesta inmune, la respuesta a las vacunas y demás, ¿no? Con estos grandes cambios que hay en el desarrollo, pues sabemos que hay también cambios en la distribución del agua corporal total. Más o menos el agua intracelular es alrededor del 40% desde el momento de la concepción, Pero al nacimiento, los bebés son prácticamente 80% de su peso es agua y esto puede ser 90% del peso eh, en niños prematuros y va disminuyendo el agua a medida que pasa el tiempo hasta alcanzar más o menos 60% y esto es sobre todo a expensas del agua del espacio extracelular, ¿no? Eh, y esto influye también, por supuesto, en cómo se manejan los medicamentos, ¿no? Entonces, en los determinantes de la relación de un medicamento de la dosis a la respuesta terapéutica, por un lado tenemos la dosis que se prescribe, que el médico prescribe, luego viene la adherencia terapéutica, si el paciente la toma, la ingiere, a veces los niños son muy sangrones y no les gusta el sabor de determinada suspensión, la pueden escupir o vomitar, ¿no? Esto es ya la dosis que se toma, va a depender de la formulación. Una vez que se ingiere, vienen los procesos de absorción, distribución, metabolismo y excreción, que a esto le llamamos farmacocinética, y de esto van a depender las concentraciones en la sangre. El fármaco libre es el que va a hacer el efecto terapéutico, ¿no? Y influye mucho las características del medicamento para ver en dónde se va a distribuir y las cantidades en el sitio de acción. Y aquí viene lo que nosotros llamamos farmacodinamia, que es la respuesta farmacológica, que a su vez puede ser la terapéutica que estamos buscando o bien la toxicidad y los eventos adversos. En este gráfico les presento tres curvas de concentración en sangre contratiempo, lo que nosotros llamamos áreas bajo la curva de concentración tiempo, y les estoy marcando aquí entre la línea sólida, que sería la concentración máxima tolerada, y la punteada, la concentración mínima efectiva, lo que nosotros llamamos la ventana terapéutica. Si nosotros sobrepasamos la línea negra, como la curva A, tenemos más riesgo de tener toxicidad, sobre todo las toxicidades, muchas de ellas se relacionan con el pico de los medicamentos, la concentración máxima, y esto lleva a una falla terapéutica. La curva C, si bien levanta, no alcanza la concentración mínima efectiva, lo que llevaría a un efecto insuficiente y una falla terapéutica. Y la única curva que está dentro de la ventana terapéutica sería la curva B, ¿no? Hablando del manejo de los medicamentos por el organismo, es importante hablar de este concepto de ontogenia, que es el desarrollo de un individuo hacia la madurez, en donde hay cambios funcionales en el manejo de los medicamentos que se va a adquirir por patrones de expresión de diferentes genes a diferentes edades, además de la variabilidad genética que se hereda o que puede dar por exposición ambiental, por la epigenética. Y esta relación entre los genes y lo que se manifiesta, genotipo, puede cambiar en el crecimiento y desarrollo. Entonces sabemos que estas vías de biotransformación son muy importantes para mantener las concentraciones de ligandos pequeños que participan en el crecimiento y la diferenciación, pero también en la eliminación de sustancias que producimos endógenas para crecer, o sea, y ya después estas mismas vías las utiliza el organismo para el manejo de los medicamentos, ¿no? Esta lámina, que si bien ya tiene más de 20 años, ilustra muy bien los diferentes cambios que se dan en el organismo durante el desarrollo. Hay grandes cambios en la capacidad metabólica del hígado, se van expresando diferentes enzimas. En los niños, por ejemplo, la piel es muy delgadita y la vía cutánea es una vía por la que más bien se pueden intoxicar fácilmente, ¿no? Hay grandes cambios en la función renal y en la capacidad de concentrar la orina y de depurar los fármacos. También hay cambios en la función gastrointestinal, en la capacidad de secretar ácidos y por ende de la absorción de los diferentes fármacos según sus características. Los fármacos ácidos se absorben mejor en medio ácido. También hay cambios en la motilidad intestinal y también aquí influye la dieta del paciente. Los niños que son alimentados al seno materno tienen una motilidad intestinal más rápida que los niños alimentados con fórmula, ¿no? Y también van cambiando los sitios de distribución. Ya hablamos de esto de la distribución del agua corporal total y de la grasa corporal, ¿no? En esta imagen les muestro cómo los niños pequeños, sobre todo, expresan al nacimiento este citocromo CYP3A7 y a medida que van creciendo, van expresando más CYP3A4. Entonces, el tipo de metabolitos cambia según la edad y hay metabolitos de los fármacos que pueden ser metabolitos activos o metabolitos tóxicos. En relación a la distribución, en esta lámina les presento en el 1 un medicamento que se distribuye principalmente dentro de los vasos intravascular, no sale hacia el espacio intersticial o hacia dentro de las células. El número 2, se distribuye muy bien en el líquido intravascular e intersticial, pero no entra a las células. El 3 se distribuye ampliamente dentro y fuera del espacio vascular y dentro y fuera de las células. Y el grupo, lámina 4, son los que tienen un predominio para entrar dentro de la célula y son diferentes tipos de distribución y también diferentes, entonces, serán los sitios de acción y los efectos del medicamento. Ya les había dicho que el fármaco libre, el que no está unido a proteínas y a tejidos, es el que va a tener la capacidad de ejercer el efecto terapéutico, pero también el que se puede transformar, metabolizar a compuestos, nosotros les llamamos más polares para que puedan ser excretados por la bilis o por la orina. Entonces, el fármaco es el que puede hacer el efecto y también el que se puede eliminar más rápido. En cambio, el fármaco que está unido a proteínas, pues tarda más en hacer el efecto terapéutico y tarda más en biotransformarse y en eliminarse. Y hay diferencias en la unión a proteínas entre los niños y los adultos. Por ejemplo, los niños recién nacidos pueden tener elevación de la bilirrubina y entonces cambian, los medicamentos compiten con la bilirrubina por la unión a proteínas. Hay diferentes propiedades de unión entre la albúmina fetal y la albúmina del adulto, o sea, y esta se va produciendo conforme crece el niño. Hay diferentes propiedades en la unión de las globulinas. Los niños más pequeños tienen un pH sanguíneo más ácido y también hay diferencias en la cantidad de ácidos grasos libres que influye en esta unión a proteínas. Por otro lado, tenemos el asunto de la función y la eliminación renal. La mayor parte de los medicamentos se van a transportar en forma activa a los túbulos renales y pues los niños en general, si nacen de término, tienen 1 millón de nefronas en cada riñón. Las nefronas se forman hasta la semana 34, pero si el niño es prematuro, pues le van a tocar menos nefronas. Y también los niños con peso bajo al nacer van a tener menor cantidad de nefronas. Solo que el número de nefronas es difícil de medir y entonces utilizamos como un surrogado de esto la estimación de la tasa de filtración glomerular, que sería la depuración, que es el volumen de plasma que es filtrado por el riñón por minuto. Esta estimación de la tasa de filtración glomerular alcanza el valor del adulto alrededor de los 18 meses, ¿no? Entonces aquí tenemos cómo va cambiando esta tasa de filtración glomerular conforme crecen los niños y podemos ver que pues más o menos es aquí en hombres y mujeres. Entre los 2 y 12 años, la tasa de filtración va de 133 más menos 27, ¿no? En los neonatos debemos de considerar además las condiciones de la mamá, si hubo diabetes, obesidad, el estado nutricional y la exposición a medicamentos durante la gestación que pueden afectar el número de nefronas y también la función renal en ese recién nacido. Y la situación es que generalmente utilizamos fórmulas que utilizan esta sustancia que se llama creatinina sérica, que deriva del músculo. Sin embargo, la creatinina sérica no es confiable para calcular esta tasa de filtración glomerular en los primeros 3 días de vida. Ahora se ha propuesto que se utilicen mejor fórmulas que contemplan otra molécula que se llama cistatina C, que se encuentra en todas las células nucleares. Pero esa estimación es un problema precisamente en una etapa tan vulnerable como es el periodo neonatal, ¿no? También el menor flujo plasmático renal va a afectar la farmacocinética de los fármacos que se van a eliminar por vía renal, que ya es alrededor del 60%. Y sabemos que no solamente esta tasa de filtración es importante, sino que también es importantísima la función tubular, la capacidad de reabsorber y de secretar sustancias que va cambiando con el desarrollo, ¿no? Entonces, les había presentado al inicio las curvas de concentración contratiempo y estas son más bien las curvas de la concentración efecto, ¿no? Del lado izquierdo tenemos las curvas en los adultos y en los niños, en general, para todos los medicamentos, esta ventana de efecto son de un margen más estrecho, ¿no? Estos son algunos de los problemas que tenemos con la administración de los medicamentos en pediatría. Los niños requieren fracciones de preparaciones farmacéuticas disponibles y el cálculo de la dosis introduce una fuente de error. Generalmente en niños, si hay una formulación pediátrica, pues se tienen jarabes, suspensiones o microgránulos, pero entonces se dosifican ya sea según las características del medicamento por miligramos por kilo o miligramos por superficie corporal según el medicamento. Y el cálculo ya introduce una fuente de error. En ocasiones hay condiciones en donde no hay formulaciones pediátricas especiales, y menos para los prematuros. Por ejemplo, no tenemos hipotensores para niños y tenemos niños hipertensos. En fin, y así les puedo dar una larga lista de medicamentos que utilizamos en niños y se tienen que manipular las formulaciones de los adultos. Y en la historia de la farmacología tenemos los ejemplos de malos desenlaces con algunos ingredientes inertes que dicen, no, pues que se utilizan nada más para dar forma o sabor al medicamento, pero resulta que en los niños no son tan inocuos como se esperaba. Los nuevos medicamentos llegan tarde a la población pediátrica y muchas veces se extrapolan los datos que se tienen de los adultos, ¿no? Y se asignan concentraciones terapéuticas y dosis sin datos científicos que lo soporten, es decir, se utilizan los mismos niveles que los adultos y no se tienen perfiles de efectos adversos relacionados con la edad. Puede haber, cuando se incluyen niños, en vez de hacer curvas de concentración contra tiempo de 12 puntos de muestreo, pues se hacen muestreos limitados para no tomar tanta muestra y se hacen con 6 puntos, entonces puede uno no tener el cuadro completo, ¿no? No siempre se considera la unión a proteínas ni los metabolitos. Y si hay estudios, también no siempre se divulgan y se aplican los conocimientos de farmacocinética y algo que es muy importante, la información sobre las interacciones, ¿no? Hay que recalcar que los niños no son enanos, hay que considerar cada edad por separado, ¿no? La edad gestacional hay que considerarla siempre en los recién nacidos y la edad postnatal, ya les hablé de las edades pediátricas y de todos los cambios que hay, el tratamiento concomitante que están recibiendo y por supuesto los estados fisiopatológicos, por qué estamos dando el medicamento, qué condición estamos tratando. Ante esta situación, tanto en la FDA como en la EMA, se han desarrollado iniciativas desde hace varias décadas, de manera que se incentiven los estudios pediátricos, alargando el uso de la patente. Y digamos que las diferentes estrategias han funcionado porque si podemos ver que sí han habido cambios, hasta esto es información de la FDA hasta 2023, en donde se ve el aumento de los cambios en la etiqueta, tanto para fármacos como para los biológicos, a raíz de eh, todas estas iniciativas de ley que fomentan la investigación pediátrica, que yo creo que es importantísima para poder hacer medicamentos y uso de los medicamentos en niños en forma más segura, ¿no? Muchísimas gracias.
Muchísimas gracias, doctora Mara Medeiros. Sin duda un tema fantástico que discutir en el Día de la Seguridad del Paciente. Por favor, le pedimos que siga conectada y al final tendremos la sesión de preguntas y respuestas, ¿no? Las preguntas a todos nuestros asistentes que nos están viendo a través de YouTube y de Facebook. Les pedimos, por favor, que vayan anotando sus preguntas en el chat de ambas redes para que las podamos contestar, para que aquí nuestros profesores, nuestros invitados las puedan contestar. Entonces, a continuación, permítanme presentarles a nuestra segunda ponente, la doctora Elizabeth Guadalupe Sánchez González, que presentará su conferencia titulada Errores de medicación en pediatría. La doctora Elizabeth es académica e investigadora en ciencias farmacéuticas de la Facultad de Estudios Superiores Zaragoza de la Universidad Nacional Autónoma de México. Fue responsable del programa de farmacia hospitalaria de la FE Zaragoza con el Instituto Nacional de Pediatría. Entonces, pues tiene amplia experiencia justamente en el trato de este tipo de eventos que suceden en nuestros pacientes pediátricos, en donde implementó servicios farmacéuticos, sistemas de recolección de medicamentos no útiles y sentó las bases para el desarrollo del sistema de dispensación en dosis individualizada y el sistema de distribución en dosis unitaria. Dirigió el Comité Integral de Proyecto de Farmacia Hospitalaria. Ha promovido acuerdos de colaboración con instituciones para programas de investigación y enseñanza de las ciencias farmacéuticas, con servicio social y práctica clínica en institutos de tercer nivel de atención como el Instituto Nacional de Cardiología. Y también en marzo de este año, muchas felicidades doctora, recibió el reconocimiento Sor Juana Inés de la Cruz que otorga la Universidad Nacional Autónoma de México a mujeres destacadas, mujeres académicas e investigadoras que justamente promueven la frontera de investigación en México. Adelante doctora, le cedo la palabra.
Muchas gracias, doctora Liliana. Es un gusto para mí poder acompañarles en esta sesión y agradezco a ISoP la gentileza de considerarme para este programa. Me voy a permitir platicar con ustedes acerca de los errores de medicación, precisamente hablando desde un riesgo prevenible y hacia una cultura de seguridad, que creo que es lo más importante que puedo resaltar. Les platicaré en esta sesión acerca de mi expertise, precisamente como una profesional de la salud, pero también como la madre de un guerrero. Yo quiero platicarles un poco más desde una perspectiva un poco más sensible humana y sobre todo hablando de que cada dosis que damos a un paciente pediátrico debe ser un sinónimo de seguridad. ¿Por qué? Porque siempre tenemos la incertidumbre y ya los tratamientos de los pacientes pediátricos con comorbilidades, con enfermedades crónico-degenerativas, son bastante angustiantes para el paciente y para todo el equipo que lo acompaña desde la familia. Por eso tenemos que tratar de impulsar diferentes estrategias para reducir los riesgos. Cuando empecé a platicar con unos colegas acerca de la importancia del tema, tuve el gusto de sentarme ahora sí que a la mesa con el doctor Maza y con el doctor Héctor Torres y platicábamos de la urgencia, la necesidad, pero sobre todo, ¿desde cuándo tenemos la claridad de los errores de medicación? Y el doctor Maza me compartía que precisamente desde 1880 empezamos a documentar los errores de medicación en pediatría. Ahí encontramos como de los más antiguos, no solo por el error, sino por la estrategia de prevención. Desde entonces ya estamos usando con estrategias de prevenir que hay un riesgo para el paciente. En 1880, donde había contagios de gonorrea de forma transversal, se empezaron a utilizar las sales de plata de forma oftálmica para los pacientes. Sin embargo, había a veces confusión por el tipo de gotero. Y entonces se incentiva el uso de un gotero de forma hexagonal precisamente para evitar confundir este medicamento. Y esa es una estrategia que tenemos documentada. Y como esta vamos a ver muchas, sin embargo, aún hay riesgos relacionados cada vez con los tratamientos, cada vez con los sistemas. No es que no se trabaje, simplemente lo que es un esfuerzo por prevenir tiene que ser continuo. Y por ello me voy a permitir platicarles un poco pues, de la magnitud de este problema, hablar de las estadísticas que tenemos en pediatría, de estos factores de riesgo y vulnerabilidad pediátrica, las etapas donde se pueden generar estos errores y específicamente en pacientes oncológicos, que es un poco donde más me he desarrollado yo. Yo quiero hacer mucho énfasis en que los errores de medicación son incidentes prevenibles. No quiere decir que van a ser totalmente eliminados de los sistemas. Simplemente lo que buscamos es cada vez incentivar más la prevención y por lo tanto necesitamos tener una cultura de la prevención. ¿Qué tan grave es este problema? Pues estimamos nosotros que en los hogares a nivel mundial, cada 8 minutos tenemos un incidente fatal relacionado con el uso de los medicamentos pediátricos. Estos casos se vuelven más importantes por dos factores, ya nos lo platicaba un poco en la ponente anterior, pues precisamente por el uso de medicamentos fuera de la ficha técnica o fuera del instructivo o fuera del registro, pero porque son necesarios porque no hay un medicamento diseñado para niños. Y el otro riesgo es la manipulación. La manipulación que tenemos que hacer tanto hospitalaria como de tipo domiciliario, precisamente para poder tener la posibilidad de atender al paciente. Y estos son los dos puntos críticos y centrales sobre los que tenemos que trabajar un poco para poder decir nosotros que estamos abordando nuevas estrategias. Es bien claro que tenemos mucha mayor prevalencia en paciente pediátrico, 3 veces más que en adulto. y se estima que de cada 1,000 pacientes pediátricos, entre ellos va a haber entre 100 a 400 errores de prescripción solamente. Son datos realmente alarmantes. En un estudio que realizamos en el año 2010 en un hospital de tercer nivel en el área de infectología, revisando estudios de 144 pacientes, detectamos en ellos 741 errores de medicación, del cual el 80,97% correspondían a errores de prescripción. Y esto pues es un dato que nos pone una señal especial en lo que es la prescripción. Las estadísticas internacionales y las nacionales nos van a decir qué es lo que tenemos mucho que tomar en cuenta. A nivel internacional, la Academia Americana nos dice que 1 de cada 5 niños recibe al menos un error en medicación. Y esto es durante la cadena de atención médica. Para lo que son otros casos, vamos a tener 19% de los eventos adversos de los niños hospitalizados van a corresponder al 50% de los errores en dosificación incorrecta. Es decir, algo en el cálculo para dar la dosis adecuada no fue de la manera correcta gestionada. Y en el ámbito hospitalario, pues los errores de medicación corresponden a un 15% de los pacientes pediátricos que reciben medicamentos por vía intravenosa. Esta es otra alerta. Los errores cuando estamos o preparando la medicación intravenosa o cuando se está administrando. Y para México, este dato que nos presenta el Instituto Mexicano del Seguro Social es súper importante. 22% de los errores de medicación van a ocurrir ya documentados en el proceso de prescripción. Son datos que tenemos de lo que son nuestros sistemas de medicación para nivel internacional y para México. Y estos datos están relacionados también con los factores de riesgo y vulnerabilidad pediátrica. Ya no lo venían diciendo las estadísticas, hay datos porque se requieren cálculos complejos. Con mucha frecuencia, a veces durante el cálculo de la administración de dosis, no se consideran que deben ser de acuerdo a peso o a superficie corporal y se hacen con el cálculo en edad. Necesitamos estar muy pendientes de las estrategias con las cuales se gestiona este caso. El uso de los medicamentos que están en off-label o fuera de la especificación, pero que son necesarios y que eso genera, pues obviamente que haya una ausencia de formulaciones pediátricas. Cuando hay ausencia de formulaciones pediátricas, con frecuencia se van a buscar algunas estrategias. En algunos países tenemos el problema de suministro y desabasto. No quiere decir solamente que no estén en el sistema de salud público, simplemente no llegan a nuestros países. Y eso también requiere que se tengan que abordar nuevas estrategias. Ya nos lo platicaban un poco, los nombres similares. Y datos muy inquietantes son la falta de etiquetado adecuado cuando el medicamento llega a piso, cuando hay confusiones en la dosis, en la edad del paciente y en el mismo nombre del paciente. Es importante que nosotros, como ya nos decían, tengamos muy claro que no son pacientes pequeños y que entonces estas formulaciones con las que los atendemos deben ser adecuadas y deben ser correctas para poder dar una mejor atención y disminuir el riesgo de nuestros pacientes. Es bien importante cuando nosotros hablamos de estos factores de riesgo que podamos saber cómo es mejor atenderlos. Por ejemplo, en el cálculo de dosis, para que nosotros no tengamos sobredosis o subdosis, lo que tenemos que tratar es evitar las confusiones con los datos de miligramos por kilogramo o miligramos por metro cuadrado, si es por peso o por superficie corporal. Hay que ver errores en el punto decimal. A veces subestimamos o minimizamos la diferencia en el manejo de decimales y esto tiene un amplio impacto, sobre todo en pacientes de tipo oncológico. Las formulaciones a veces requieren manipulación, sin duda alguna la necesitamos y esto puede generar dosificaciones imprecisas. Es muy común que se vea que hay medicamentos que se trituran o se manipulan para darlos en algún tipo de jugo o en algún tipo de solución que sea más agradable al paciente. Sin embargo, a veces puede quedar adherido a la superficie donde se preparó y eso hacer que nuestra dilución sea correcta. A veces ponemos demasiado jugo y con que se tome una parte es suficiente, entonces el paciente no ingirió la dosis adecuada. Y el uso de cucharas. En este esquema me permití ponerles diferentes cucharas cuando le decimos al cuidador o al tutor o al papá del pediátrico, dénselo con una cuchara o una cucharadita de medicamento. ¿De qué tamaño es la cuchara? ¿Qué va a pasar cuando nosotros tenemos una dosis mayor porque la cuchara era más grande? Puede parecer algo que no va a suceder y sin embargo en la terapia pediátrica en el día a día sucede. Cuando nosotros tenemos el uso de medicamentos fuera de la especificación, nos involucra que no hay guías para la prescripción y dosificación pediátrica. Eso nos da un reto. Como profesionales de la salud necesitamos el desarrollo de guías farmacoterapéuticas, necesitamos el diseño de guías claras de prescripción y hasta dónde va a tener validez el que los administremos. No podemos pensar que todos los medicamentos pueden ser empleados de forma idéntica, incluso dentro de la población pediátrica. Habrá que tener consideraciones especiales y sobre todo cuando hablamos de pacientes que tienen algunas patologías o algunos padecimientos que requieren dosis muy precisas y muy exactas. Y lo que platicábamos un poco de desabasto. Tal vez las familias busquen de forma en farmacias sustituyentes y a veces quien hace la sustitución no es una persona parada para ello. La sustitución, por ejemplo, de un jarabe a un comprimido para un paciente pediátrico que tenga problemas de deglución, para un paciente que no pueda tragarlo, va a hacer que no se reciba la medicación en la dosis que se espera y esto nos genere un error y un impacto a su tratamiento. Las etapas donde se generan mayor cantidad de errores que están documentadas a nivel global está la prescripción. Y dentro de la prescripción podemos hablar que con mucha frecuencia es que la receta médica no puede ser comprendida de forma clara, no se lee de forma correcta y pueden darse cambios precisamente porque no fue comprendida. Eso nos lleva a una reflexión. Hay que tener cuidado en cómo se documenta la prescripción para el paciente. Hay muchos médicos que están buscando alternativas ahora de darla escrita en computadora más que a mano para evitar estos errores. Y por ahí nos platicaban hace rato cuando platicamos en la introducción de la automedicación. Hay una automedicación responsable desde el conocimiento. Y entonces esto nos involucra como profesionales de la salud y también como padres a tener que estar con el conocimiento de cuál es la medicación y cómo debe tomarse. Y no promover la automedicación cuando no tenemos el conocimiento o el respaldo para poder promover o gestionar el uso del medicamento. La dispensación que está más relacionada con los usos hospitalarios y un poco con lo que es nuestras farmacias comunitarias, hay que tener cuidado de que lo que nos están entregando o lo que estamos dispensando nosotros como profesionales es realmente el medicamento que nos están solicitando y realmente preguntar al médico cuando queremos hacer una sustitución terapéutica, que esté muy claro el por qué se está dando y quién le está autorizando. Así como en la preparación necesitamos verificar que sea con las características deseadas. Puede estar pensándose quizá en forma domiciliaria que no pasa nada si yo al niño le doy el medicamento con un jugo que puedo cambiar el pH y generar una degradación. Tal vez un cambio físico-químico tan solo en la preparación y puede alterar que reciba productos de degradación para los cuales nuestro paciente pediátrico no tenga los mecanismos todavía desarrollados para que no tengan un impacto en su salud. Ahora bien, en cuanto a la administración, hay que considerar dos aspectos. Lo que pasa en la administración hospitalaria del ambulatorio. Si bien la hospitalaria está vigilada por los expertos en los medicamentos, por los expertos en sistemas de salud, la ambulatoria no. La ambulatoria puede estar delegada a veces al paciente mismo, a veces tendrá para los tutores y a veces para un cuidador que no tenga los conocimientos. Y hay poca cultura del monitoreo, saber qué pasa una vez que lo recibe, saber que a lo mejor nosotros con un paciente oncológico puede tener cambios importantes que puede desarrollar una trombosis o que puede generar una anemia aún más grave, precisamente derivado del medicamento oncológico que se está administrando. Y es muy importante que tengamos muy claro cuáles son los síntomas o cuáles son los datos que van a ser de alerta para nosotros para poder dar un buen seguimiento y en algunos casos justificar un cambio en la pauta o en la dosis terapéutica. ¿Qué genera estos errores? Con mucha frecuencia el trabajo, la carga de trabajo, la fatiga. Cuidar al paciente pediátrico requiere un esfuerzo extra, porque a veces necesitamos tener una comunicación mucho más estrecha y mucho más cercana cuando esto es posible, y a veces no lo es porque nuestros pacientes todavía no desarrollan esas habilidades. A veces el problema sí puede ser el cálculo de dosis, pero también puede ser la falta de capacitación en farmacología pediátrica y que no tenemos en realidad en muchos países personas totalmente formadas y preparadas para este tipo de datos. Es muy importante que nosotros tengamos claro que pueden darse confusión en los nombres. Por ejemplo, en el caso de tratamientos oncológicos, es muy común confundir vincristina con vimplastina o, por ejemplo, un larotrectinib con el entrectinib. Entonces, necesitamos que la indicación sea totalmente verificada. Nuestros criterios de checar si realmente estamos dando el medicamento correcto, hay que insistirlos. Y para esto nos servirán mucho las auditorías. A veces eso nos va a ayudar a implementar estrategias para que se puedan reducir este número de datos de error y que nosotros podamos verificar de forma totalmente fehaciente qué es el medicamento el que tenemos que administrar. Además, necesitamos verificar las dosis. Nosotros tenemos que checar que sean realmente los cálculos. Para eso nos podemos valer del uso de tecnología sin duda alguna, pero sin embargo, mientras nosotros estamos gestionando, cuando nosotros introducimos el dato, eso puede conllevar un error. Es muy importante remarcar que la Sociedad Internacional de Oncología Pediátrica estima que el 20% de los errores de medicación en oncología pediátrica están causados por dosis incorrectas. El paciente pediátrico tiene una particularidad, se va a ir desarrollando, va a ir cambiando de forma muy rápida en tamaño y en peso. Pero el paciente pediátrico con tratamiento oncológico, la variación de peso puede darse en días. A veces, si bien nos va en semanas, pero puede darse de un día para otro precisamente por el tipo de medicamentos que empleamos. Y esto es muy importante tenerlo en cuenta. Dentro de estos factores que vamos a encontrar asociados al riesgo para el tratamiento de los pacientes oncológicos, pues está la complejidad de los tratamientos. A veces nuestros pacientes no reciben solamente un medicamento, reciben medicamentos que pueden requerir que nosotros demos tratamientos previos, un poco un manejo de analgésicos o un poco medicamentos que pueden proteger el estómago o que puedan ayudar a evitar las náuseas o el vómito, que sean antieméticos. Entonces, no es un solo medicamento el que estamos administrando. Y eso también no está aunado a la variabilidad de las dosis por los cambios de peso que el paciente pueda tener de un tratamiento al siguiente, además del manejo de los efectos secundarios. La quimioterapia, sin duda alguna, es uno de los tratamientos que más requiere la vigilancia y el cuidado de estos efectos, porque pueden ser efectos que comprometan incluso la integridad de nuestro paciente. Además de las interacciones medicamentos así nutricionales, es muy común que nuestros pacientes cuando se van a domicilio tengan diferentes pautas alimenticias y estas pueden ser ricas en fibra, ricas en lácteos o pueden ser carentes de alguno de los elementos que pueden ser carentes de vitamina o el paciente simplemente no quererlas y entonces tendemos a dar alimentos que puedan ayudar a que el paciente se mantenga alimentado, pero no con ello nutrido, y que pueden generar complicaciones. ¿Qué va a pasar? Pues que necesitamos que el tratamiento realmente para minimizar el riesgo de medicación sea de forma multidisciplinaria, que tenga que ser abordado por cada uno de los profesionales de la salud y que estos estén altamente especializados para administrarlos con una gran precisión. Algunas de las estrategias claves para la prevención de los errores, pues precisamente será la prescripción segura, usar la prescripción electrónica y con alertas. Y eso tendría que ser implementado por los sistemas de salud, buscar una dosificación pediátrica mucho más precisa, en especial en pacientes que tienen algunas comorbilidades, en pacientes que tengan algunos otros problemas asociados a sus tratamientos. A veces el paciente empieza con solamente un cuadro, por ejemplo, de infección, después tiene un diagnóstico de leucemia y probablemente después tenga un problema o de daño hepático o de daño renal. Y eso nos va a llevar a tener que hacer dosificaciones aún más precisas porque va a haber cambios en el metabolismo y la excreción del medicamento. Necesitamos verificar que las dosis tanto a nivel hospitalario como a nivel ambulatorio, sean precisas. Y esto involucra que nosotros dejemos de indicar cucharadas. Necesitamos dar instrucciones claras para que se midan los volúmenes correctos. Es muy difícil, por ejemplo, cuando se indican en algunos casos los esteroides y si le indica al papá o al tutor o al cuidador que los medicamentos deben ser partidos en mitades, en cuartos o hasta en octavos. Eso complica mucho la administración exacta y hay que darles una educación tanto a la parte médica, a la parte de enfermería, pero también a los tutores y a los padres. ¿Y cómo podemos hacer esta prueba de la enseñanza? Es pedir que nos repitan la instrucción que nosotros estamos dando para la administración del medicamento. Es pedir que siempre se verifique qué es lo que nosotros indicamos, los cuidados que dio el médico y se esté repitiendo para que se haga una cultura en la administración y en la mejora del tratamiento. Y finalmente, pues también la cultura de la seguridad. A veces da mucha pena decir algo está fallando. Se tiene mucho miedo a la represalia, porque todavía no tenemos una cultura desarrollada donde el decir que algo falló no quiere decir que es una cacería de brujas, sino que se está invitando a que se trabaje de mejor manera armónica. Los errores de medicación en pediatría son prevenibles, pero no son inevitables. Van a seguirse dando, por supuesto, pero que se den en la menor cantidad, con la menor frecuencia posible y que sean con el menor impacto que se pueda tener. Es bien importante para favorecer esta cultura de seguridad que hablemos con claridad, que hablemos desde enfoques útiles, que usemos pictogramas para tomar los medicamentos, que incentivemos a nuestros pacientes cuando ya lo pueden hacer y lo pueden comprender, a que asuman la responsabilidad de sus tratamientos tanto en medicamentos oncológicos o con pacientes que pueden estar solicitando el uso de insulina o con pacientes que requieren algún otro medicamento, por ejemplo, para crisis convulsivas. Hay que decirles que no se toma solo y que no deben repetir las dosis. Pero algo muy importante es que no podemos hacer que parezcan dulces, que parezcan un juego o un premio para que el niño no relacione el medicamento con algo que pueda generar un error más grande. Es importante explicarlo a su edad, muy importante explicarlo con historias que ellos comprendan, pero también es importante que nosotros no tratemos de hacer un cuento de lo que son los tratamientos de medicamentos. Por supuesto que se vale utilizar personajes y colores, pero lo que no se vale es que nosotros le pongamos a lo mejor a una tableta o a un medicamento un sentido de un dibujo infantil para que ellos no lo relacionen con algo divertido. No le pondríamos nosotros nunca de ninguna forma una cara feliz a un explosivo. ¿Por qué? Porque eso generaría un riesgo. No tendríamos por qué hacerlo a los medicamentos. Y es muy importante enseñar a los niños que los medicamentos requieren la supervisión de un adulto. Así estén en adolescencia, porque si hay alguna complicación, debe ser atendida y comunicada a una persona que pueda tomar la decisión, que pueda ser incluso quien lo notifique al médico o quien gestione con el equipo de salud cómo debe ser atendida. ¿Cómo educar entonces sin llegar a que esto se vuelva trivial? Pues primero explicarles a nuestros pequeños que los medicamentos son importantes y que son parte quizá de su día a día, que quizá van a ser parte de su crecimiento y de su vida durante muchos años, si no es que la acompañan de forma permanente. Pero es importante que tampoco lo confundamos con algo que pueda ser un premio o un castigo. Tiene que ser un lenguaje muy claro y para su edad, pero tampoco que lo llevemos a infantilizar para que ellos no piensen que es una banalidad y sobre todo contar con recursos visuales. La educación que tenemos que dar para disminuir los errores de medicación en algunas poblaciones cuya vida toda va a estar relacionada de forma permanente con los medicamentos, tiene que involucrar a los papás, a los tutores y a todos aquellos que en algún momento tienen el rol de cuidador. De otra forma, a nivel domiciliario se seguirán presentando los errores de medicación. Y si bien son muy importantes a nivel hospitalario, por supuesto que también a nivel comunitario siguen siendo una pauta súper importante. Es para mí muy importante hacerles el cierre de esta sesión comentándole que sí podemos hacer esta reducción de los errores de medicación y que todo está enfocado precisamente en mejorar su calidad de vida. Sin duda alguna podemos utilizar tecnologías, educación continua, enfoques colaborativos, pero creo que más allá de estar buscando estrategias separadas, tenemos que pensar en formar equipos de trabajo que conjunten las pautas, las estrategias y el esfuerzo de todos para proteger a la población, a una de las más vulnerables. El trabajar en equipo, cada uno de los profesionales de la salud nos ayudará a cumplir esta meta de medicación sin daño, que nosotros podemos garantizar y robustecer la seguridad de nuestros pacientes. Y por mi parte, pues un gusto haberles compartido esta información y yo quedo a sus órdenes. Muchísimas gracias.
Muchas gracias, doctora Elizabeth. En verdad que su presentación ha sido un tema muy interesante, pues cómo abordar todos estos orígenes de los errores de medicación, pero también cómo se pueden prevenir con diversas acciones puntuales desde nosotros como profesionales de la salud, pero también como cuidadores o también, como bien lo menciona, como mamás, ¿no? Eso es muy importante. El mensaje llega a toda la comunidad y al final del día, pues terminamos siendo pacientes, pero en esta ocasión también terminamos teniendo un paciente en casa y eso es algo que siempre hay que tener visible. Bueno, pues recuerden por favor dejar sus preguntas y seguir la conversación en redes sociales usando los hashtags que están viendo justamente en la pantalla. Dejen sus comentarios y sus preguntas porque al final de la sesión empezaremos con las preguntas y respuestas. Continuando entonces con nuestra agenda, es un placer presentarles al maestro Heriberto Gómez Gaitán. Él es nuestro último ponente de la sesión que presentará la conferencia titulada Prevención de errores de medicación en entornos hospitalarios pediátricos. El maestro Heriberto Gómez es jefe del Servicio de Calidad del Hospital Infantil de México Federico Gómez. Es profesor de asignatura definitivo A en la Facultad de Enfermería de la Universidad Nacional Autónoma de México y además es director de certificación profesional del COMLE Asociación Civil. Bienvenido, maestro Heriberto. Adelante con su tema, por favor.
Muchas gracias. Buen día. La verdad es que para mí es un gusto y un placer estar este día con ustedes compartiendo estas experiencias que se relacionan justamente con la prevención de errores de medicación en entornos hospitalarios. Y bueno, agradecer también la invitación, que sin duda, pues esto, bueno, es un espacio de intercambio de experiencias. Y bueno, lo que yo voy a abordar desde este contexto de la prevención de errores, pues es desde el contexto del área de calidad. Y en este sentido, pues abordaré algunos aspectos, sobre todo generales, que tienen que ver con una perspectiva de la calidad para garantizar la seguridad de las niñas, niños y adolescentes en el contexto pues, de evitar y disminuir los riesgos posibles durante su atención. Y bueno, pues estamos en el mes prácticamente de la conmemoración de del Día Mundial de la Seguridad del Paciente, en el que prácticamente los cuidados seguros para todos los recién nacidos y todos los niños, y bueno, pues específicamente se hace hincapié en la necesidad de establecer medidas estrictas para proteger a los niños de daños que son prevenibles en la atención a la salud. Y sin duda uno de los principales retos que tenemos en las organizaciones, pues es la disminución de estos riesgos asociados a los procesos de medicación. En este sentido, pues bueno, la Organización Mundial de la Salud, a través de esta estructura que ha establecido en la que le he dado visibilidad a cada una de las partes que integran estos modelos de atención, pues está la integración de eliminar o evitar todos los daños que estén asociados a la atención a la salud, la seguridad en los procesos clínicos y algo que me parece fundamental y que es parte de las estrategias que se han dado con mayor visibilidad a lo largo de los años, pues es prácticamente la participación de los pacientes y de sus familias. Es decir, la voz que ellos tienen en el proceso de atención es fundamental, sobre todo para establecer estas políticas y programas de manera que respondan a las necesidades de los modelos centrados en las personas y las familias. En este sentido, pues las experiencias que nos pueden aportar, pues son fundamentales para mejorar nuestros procesos de atención. Y bueno, pues en este sentido también entra y juega un papel fundamental la información y la educación a los pacientes y sus familias. Entonces, este tema relacionado con todos estos riesgos que se pueden identificar en en la atención, pues, y además que es información que nos pueden aportar estos pacientes y familias, pues es fundamental. De ahí que, bueno, pues se retoma esta estrategia a nivel mundial y pues en este plan mundial de calidad y seguridad del paciente. En este contexto, pues bueno, la seguridad del paciente, sobre todo el ámbito pediátrico, pues confiere ciertas características que le dan esta condición de vulnerabilidad y que me parece importante considerarla, sobre todo si hablamos de identificación de riesgos y la prevención de los errores. En este sentido, pues es considerar una vulnerabilidad del contexto biológico, desde el contexto social, desde el contexto emocional y bueno, desde el contexto cultural, que es algo que tendríamos que considerar dentro de nuestras organizaciones, ya que el tema cultural pues es uno de los principales elementos y condiciones por las que los pacientes en algún momento pues no se llega a comprender la información o no es claro lo que se está tratando de compartir, pues bueno, porque tienen algunas condiciones desde el punto de vista cultural que tendremos que reconocer para poder hacer llegar la información. En este sentido, pues bueno, ellos prácticamente en la población pediátrica está completamente, dependen de sus cuidadores y del equipo de salud, pues para garantizar una atención segura. Como se ha comentado en las sesiones, el mayor riesgo de los eventos adversos, pues que se presentan en los niños y que están relacionados con la medicación, pues tiene diferentes elementos que pueden hacerlo vulnerable, sobre todo por las variaciones en el peso, en la edad y en el desarrollo fisiológico, y que según la Organización Mundial de la Salud, pues los errores de medicación son una de las principales amenazas para la seguridad infantil en los hospitales. Y bueno, eso es algo que nos llama a poder establecer acciones que puedan mejorar estas condiciones. En otras condiciones, pues la necesidad de generar entornos que sean en- específicos, sobre todo para las unidades pediátricas y que, bueno, pues estas deben considerar una infraestructura y protocolos que puedan ser diferenciados con el fin de reducir estos riesgos. Y bueno, el Instituto de Medicina destacó que se requiere un abordaje específico para la prevención, pues, de errores médicos que estén o que se puedan relacionar con estas condiciones de entornos de los pacientes. Y un elemento fundamental, pues, es la participación familiar. Este como eje de seguridad, donde los padres y los cuidadores, pues, son aliados claves en la detección temprana de riesgos y en la verificación de procesos, tanto como pueden ser procesos de medicación, como procedimientos, como la propia identificación correcta del paciente, y que bueno, pues es Y es necesario dar esta visibilidad, dar esta importancia y relevancia a la participación de los familias, de las familias. Y bueno, pues en este sentido, la Young Commission establece o enfatiza la importancia de la comunicación clara con la familia como parte fundamental de la seguridad en la atención de los pacientes pediátricos. Y bueno, eh, por supuesto, estos modelos que están centrados en las personas, estos sistemas o grandes modelos que están prácticamente centrados el análisis de sistemas, pues bueno, tienen algunas condiciones que pueden generar algunos riesgos y que estos riesgos se puedan materializar en problemas o daños a los pacientes en el que se ven involucrados procesos que pueden ser procesos mentales incorrectos con relación a la atención o los errores que se muestran como una consecuencia y no como una causa. En este sentido, me parece que es importante analizar la raíz de estos problemas, la raíz de por qué ocurren estos errores o por qué ocurren estos problemas y que bueno, pues esto seguramente nos dará la estrategia para establecer mejores acciones de prevención. Pero bueno, esto implica, además de reconocer y de identificar estos errores, porque me parece también importante que además de todas las referencias bibliográficas que tenemos con relación a los errores relacionados con la seguridad del paciente, pues también es un elemento fundamental que el personal que estamos a cargo de esta atención a los pacientes, pues también alcancemos esta madurez de reconocimiento de los errores. En gran medida que reconozcamos que tenemos errores o que o que identificamos riesgos, pues evidentemente vamos a poder establecer acciones que eviten daños a los pacientes. Y bueno, desde el punto de vista de calidad, significa que dentro de estos entornos hospitalarios en las que se da esta atención, pues tenemos que garantizar servicios seguros, oportunos, efectivos, equitativos y pues centrados en la persona. De tal manera que desde la perspectiva de calidad, pues se busca prevenir los errores, reducir los riesgos, favorecer la atención centrada en el niño y la familia, que prácticamente son condiciones que tendremos que garantizar como un derecho a la atención, que la calidad sea vista desde esa perspectiva y no como un privilegio en el que solo algunos puedan tenerlo. En realidad, la calidad tendrá que ser un derecho, tiene que ser un derecho para todas las personas que se encuentran en nuestras instituciones. Y bueno, solamente quiero integrar algunas referencias que tenemos y que bueno, parecieran referencias muy, pues ya de muchos años. Sin embargo, cuando las volvemos a integrar a nuestra realidad, parecieran pues muy vigentes. Y esto es nada más para contextualizar que el documento que fue publicado por el Instituto de Medicina desde 1999 de Rares Humano, construyendo un sistema de salud más seguro en el que justo se identifica todos estos errores relacionados con la atención, pues bueno, pensaríamos que ya después de muchos años, pues ya esto se ha ido disminuyendo, se ha ido atendiendo. Sin embargo, pues bueno, todavía nos falta mucho por trabajar, porque bueno, pues estos datos a lo largo del tiempo, pues han tenido poco movimiento. Para el 2006, pues con el estudio relacionado a la identificación de eventos adversos identificados en las salas de hospitalización, pues se puede identificar que aproximadamente el 42.8% pues se consideraron evitables y que bueno, pues esto eh, aún sigue vigente dentro de nuestros días. Y bueno, la prevalencia de los eventos adversos en donde en hospitales de Latinoamérica, en el que se integraron la participación de 58 hospitales, incluido México. Bueno, pues podemos identificar que el 60% de estos eventos adversos que se presentaron, pues pudieron haber sido evitables. Entonces, en este sentido, además de otros datos que tenemos, evidentemente, pues llama la atención que la mayor parte de estos eventos adversos pueden ser evitables. Y bueno, esto es un poco el contexto que tenemos con relación a lo que ocurre y al reconocimiento de las condiciones de atención y de riesgos que podemos identificar en nuestras organizaciones. Pero bueno, la prevención del riesgo desde el punto de vista institucional, pues radica justo en lo que comentaba hace un momento, en reconocer primero que existen riesgos, en reconocer que hay errores, el reconocer que tenemos que aprender de todas estas situaciones que se presentan. Y evidentemente esta información, pues bueno, tendrá que ser hasta a través de un sistema de notificación. Un sistema de notificación que nos permita justamente analizar la información, establecer cuáles fueron las causas y bueno, pues cuando identificar estas causas que generan este problema, pues evidentemente establecer acciones que estén relacionadas con nuestros principales problemas que tienen que ver con los errores. Y bueno, en este sentido tenemos reportes y notificación, capacitación o formación, las guías y procedimientos, la asesoría, la supervisión o la auditoría que de alguna manera nos va a permitir ir estableciendo e identificando estos riesgos. Y bueno, pues la consulta evidentemente del expediente clínico. Entonces, creo que la materia prima para nuestra información y análisis serán nuestros sistemas de notificación. Estos sistemas de notificación que nos van a permitir establecer cuáles son las directrices, cuáles son nuestras estrategias y acciones a seguir para establecer un mecanismo más seguro en el uso y manejo de los sistemas de medicación. Y bueno, en este sentido, pues nuestras organizaciones son tan complejas, con tantos procesos, con tantas condiciones, que evidentemente tendremos que hacer un análisis de todos estos riesgos en el que establecemos diferentes mecanismos o diferentes barreras de seguridad, pero que estas no siempre son suficientes para disminuir el riesgo. Hay condiciones que pueden ser latentes y que pueden estar presentes en todo momento y que las podemos hacer parte de nuestra cotidianidad, en nuestra rutina, hasta que ocurre un daño. Entonces, me parece que sí tendremos que ir identificando cuáles son estas condiciones latentes que pueden llevarnos a tener o a que surja una falla en nuestro proceso. En este sentido, bueno, pues tenemos procedimientos que pueden ser inadecuados o puede haber una inadecuada formación. A lo mejor la formación no es lo suficientemente sólida o la formación no es lo suficientemente necesaria o cumple con las características para que se pueda llevar a cabo cierto proceso. Puede haber mensajes confusos, no siempre la información o la comunicación es clara. La presión asistencial, que bueno, es algo que vivimos en nuestros tiempos. Las distracciones, las múltiples distracciones al estar desarrollando una tarea y que esta tarea que pueda estar interrumpida por cualquier condición, pues evidentemente también nos pone en una zona de riesgo. el cansancio, la tecnología deficiente, etcétera, que son condiciones que se encuentran latentes y que en algún momento pues se pueden alinear con otras condiciones dentro de nuestro proceso y generar evidentemente un daño. En este sentido, pues estamos involucradas las instituciones, los profesionales, los equipos, las técnicas, los procesos de atención y los pacientes y la familia. Entonces, es una forma de poder establecer que estas condiciones pues se encuentran presentes en nuestras organizaciones. Por otro lado, pues bueno, esto es algo que quiero representar porque en algún momento cuando tuvimos la pandemia, pues evidentemente sabíamos que había causas que nos estaban creando un daño, que era un daño y que bueno, pues ese daño generaba secuelas, complicaciones y que era bastante severo para nuestra salud. Sin embargo, como fuimos identificando todas estas condiciones latentes, todas estas fallas, todos estos riesgos, pues fuimos estableciendo diferentes mecanismos o barreras de seguridad que limitaran que estas condiciones, pues evidentemente se alinearan y generaran un daño a las personas. En esta condición, pues había una responsabilidad personal, había responsabilidades compartidas y que bueno, esta era la suma de todas estas condiciones para lograr un objetivo. Y esto lo pongo como ejemplo porque me parece que es muy, muy gráfico en el sentido de establecer estas acciones. Y en estas acciones, pues se estableció la distancia física, el uso de mascarillas, la higiene de manos, evitar tocarse la cara, etcétera, que eran condiciones que nos estaban haciendo como parte de nuestro cuidado, de parte de las acciones que yo tenía que desarrollar para evitar que el daño ocurriera. Y por supuesto, las responsabilidades compartidas, que prácticamente eran las pruebas, la ventilación, el tiempo de cuarentena, etcétera, vacunas, que bueno, era una condición prácticamente que pues compartíamos con otras instituciones. Entonces, cada intervención pues tiene imperfecciones, es decir, tiene ciertos orificios que pueden aumentar la capacidad de éxito o que incluso pueden llegar a ocasionar un daño. Entonces, en esta condición se pueden encontrar otros problemas, otras condiciones que podemos identificar y que podemos de alguna manera establecer como barreras de seguridad suficientes. Y bueno, en otro sentido, estamos inmersos en una organización en la que confluyen muchos procesos, muchos servicios y que el centro de la atención de todas estas condiciones que se viven en una organización, pues en el centro está el paciente y la familia. Y que este paciente y familia, pues prácticamente tiene una influencia de todos estos servicios, de todas estas personas que dirigen estos mismos organizaciones y que bueno, pues habrá que considerar que todas estas intervenciones llevan ciertos riesgos o ciertas condiciones latentes que si no identificamos, pues pueden generar un daño importante en los pacientes. Pero bueno, en este sentido, ¿qué acciones se pueden de alguna manera ir desarrollando? Pues bueno, dentro de estas condiciones es identificar los problemas. Me parece que es fundamental que en las organizaciones identifiquemos cuáles son nuestros principales problemas, de acuerdo al contexto, de acuerdo a tipo de población a la que atendemos, y que bueno, estas condiciones o estos problemas, pues también pueden ayudar a establecer acciones y de esta manera incluso comprender qué factores están contribuyendo o son el origen de estos problemas. Y bueno, el objetivo principal es aprender de las experiencias y aprender de estas experiencias a través de estos sistemas de notificación. Si no creamos una cultura de la notificación o del reporte de lo que está ocurriendo, sobre todo de aquellos elementos que tienen que ver con las cuasifallas, con los eventos adversos o con los eventos centinela, pero que además el aprender significa hacer un análisis multidisciplinario, escuchar a las personas, saber cuáles fueron las condiciones que vivieron para que estos riesgos o estos daños se pudieran materializar. Me parece que eso es un elemento fundamental dentro de los procesos de aprendizaje y que, bueno, pues esto establecerá las acciones de mejora correspondientes. Y con base en esto, bueno, pues quiero compartir que en el Hospital Infantil de México se hizo un estudio a través de este modelo SIPS del Sistema de Trabajo de Seguridad y Seguridad del Paciente, con el fin justamente de hacer un análisis profundo de qué es lo que está ocurriendo con nuestros incidentes relacionados con la seguridad del paciente. Específicamente, qué es lo que estaba ocurriendo con nuestros errores de medicación. Y bueno, pues a través de la maestra Vanessa, pues se integró este modelo a nuestro sistema de notificación de incidentes relacionados con la seguridad del paciente, en el que un elemento fundamental de análisis fueron los factores contribuyentes, es decir, todas estas acciones que desempeñan un papel importante en el origen y en el desarrollo de un incidente y que, bueno, elevan el riesgo de que éste se produzca. Retomamos este modelo a través de un análisis retrospectivo de nuestras notificaciones entre el 20 y 21 y que, bueno, pues de esta manera se pudo integrar este modelo. Prácticamente nuestro sistema de notificación en el Hospital Infantil de México, pues una notificación no solo se refiere a un tipo de incidente, en una misma notificación puede haber 2 o 3 tipos de incidentes y que, bueno, pues de esta manera se fueron clasificando y orientando de acuerdo con el modelo SIPS en el que se integra persona, tareas, herramientas y tecnologías, un ambiente interno, la organización y el ambiente externo. De tal manera que esta asociación de factores contribuyentes con los incidentes tipo cuasi falla, evento adverso, centinela, pues pudiéramos tener un reporte específico. En este, bueno, pues prácticamente pudimos identificar que el mayor número de reportes en la institución pues corresponden a eventos adversos en el 76%. En las casi fallas pues prácticamente el 24%. De tal manera que pues prácticamente se reporta más cuando ya ha ocurrido un daño al paciente. Por lo tanto, además de analizar todas las causas que se generaron dentro de estos errores o de estos daños que se produjeron, pues también era importante considerar que las cuasi fallas, pues se tienen que promover más su notificación de tal manera que podamos tener mayores acciones de prevención antes de que ocurra un daño a los pacientes. Y bueno, pues de acuerdo con la clase de incidente, pues identificamos que el mayor número corresponde a la medicación. En este sentido, corresponde al proceso de dispensación, en primer lugar, seguido de administración, suministro y pedido, selección y adquisición, prescripción, preparación, presentación envasado, almacenamiento, monitorización de efectos y transcripción. Que si lo relacionamos con la literatura, pues prácticamente no hay causas que nos puedan diferenciar en este sentido, porque continúa siendo desde el punto de vista de medicación. Bueno, en realidad la dispensación para nosotros en este sentido pues fue el mayor número de incidentes. Sin embargo, pues bueno, la literatura se referencia a algunas otras que tienen que ver con la prescripción y la preparación de medicamentos. Por otro lado, tenemos la clase de incidente de administración clínica y de infecciones asociadas a la atención. Esto es prácticamente lo que se pudo identificar como parte de nuestro sistema de notificación y también como factor contribuyente en el sentido de la participación de los profesionales de la salud, del personal de los servicios sociales u otros, del cuidador primario, pues la relación que se pudo mantener en cada una de estas participaciones como parte de los factores contribuyentes, igual que en las herramientas y tecnologías, en las tareas, en el tema de la organización y que bueno, pues cada una de esta relación de factores contribuyentes de acuerdo con el tipo de incidente, si era un evento adverso, si era una cuasi falla, de tal manera que pudiéramos tener la mayor evidencia posible para saber cuál es la asociación que tuviera con los factores contribuyentes de acuerdo con este modelo que presentamos. Y bueno, como parte de estas condiciones del aprendizaje de la cultura y seguridad del paciente desde el punto de vista de una cultura justa, pues prácticamente radica en la identificación, es decir, radica en la identificación de estos riesgos, de estos problemas, de estos errores de la notificación, que es prácticamente la parte documental, la parte que nos va a permitir obtener la información, de concentrar la información, de analizar la información desde el punto de vista multidisciplinario y del aprendizaje y justamente de esta colaborativa de cada uno de los participantes y de este trabajo interprofesional para establecer acciones que nos permitan tomar decisiones, que nos permitan establecer estrategias y acciones de mejora, pero un elemento también fundamental es la monitorización y el seguimiento que demos a cada una de estas acciones para evaluar y establecer pues nuevas estrategias a estas consideraciones. Entonces, esto es prácticamente el contexto general de de las acciones que pueden favorecer las acciones de prevención de errores relacionados con los sistemas de medicación. Y bueno, pues las prácticas para reducir los errores de medicación están en gran medida bien definidas. Prácticamente el reto es lograr que estas pues sean implementadas de manera eficaz y que podamos seguir y que podamos monitorizar para pues estar estableciendo estas acciones de mejora continua. Pues por mi parte es todo. Quiero agradecer nuevamente la colaboración y bueno, pues quedo a sus órdenes. Muchas gracias.
Muchas gracias, maestro Heriberto, por esta excelente presentación. Un tema sin duda muy importante, ¿no? Todos estos avances que se tienen desde el aspecto de calidad y cómo esto conjunta justamente las acciones preventivas para disminuir los errores de medicación. Ahora invito a nuestros ponentes a abrir sus cámaras para responder algunas preguntas de nuestro público, las cuales pues ya me las hicieron llegar por este medio, a través del equipo organizador. Entonces, vamos a iniciar con esas preguntas. Tengo una pregunta para la doctora Mara Medeiros, que ya está acá con nosotros. Sí, bueno,
¿Qué
doctora,
tal?
hola, hola,
Buenas
doctora.
tardes.
Buenas tardes. Sí, buenos días acá todavía. Buenas tardes por allá. Preguntan, ¿cómo podemos identificar una falla terapéutica y qué herramienta se podría emplear para evaluarla?
Pues la falla terapéutica, lo más sencillo es cuando el medicamento no funciona para lo que lo estamos dando, ¿no? Por ejemplo, si un paciente le estamos dando un medicamento hipotensor y no a una buena dosis y no le baja la presión arterial, eso es una falla terapéutica. Pero falla terapéutica también se puede dar cuando se presentan demasiados eventos adversos, ¿no? Con un medicamento, ¿no? Y generalmente son elementos clínicos lo que nosotros tomamos para decir que hay una falla terapéutica.
Exactamente, doctora. ¿Usted utiliza alguna herramienta o recomienda alguna herramienta para evaluar estas fallas? ¿O simplemente es por juicio clínico?
Pues generalmente lo hacemos por juicio clínico y depende qué estemos tratando, ¿no? Por ejemplo, en el caso de una infección, un antibiótico, pues si el paciente no mejora, entonces eso se considera una falla terapéutica y hay que considerar dar otro antibiótico, ¿no? En fin,
Exacto,
¿no?
muy bien.
Ujú, muy bien.
Qué bueno, doctora. Pues eso es importantísimo. Las fallas terapéuticas en pediatría son comunes y en general en la clínica, pues lo que se hace es optar por otro tratamiento. Sin embargo, las fallas terapéuticas, como menciona la doctora, pues es algo que va a afectar la efectividad del tratamiento y por lo tanto entra en un esquema de seguridad de los medicamentos. Entonces, como bien lo menciona, puede ser a través de un juicio clínico o bien utilizar algunos algoritmos que ya están validados, por ejemplo, el algoritmo de vaca, el cual pues es utilizado para investigar y para darnos luz de qué es lo que podría haber ocasionado este tipo de fallas, ¿no? Y bueno, importantísimo. Después seguimos con la doctora Liz, por favor. Usted mencionó acerca algo del uso que se da en pediatría, del uso off-label, que desgraciadamente es muy común, pero que es necesario, ¿verdad? Porque al final no tenemos indicaciones aprobadas para pediatría. Platíquenos, doctora. Entonces, el off-label, ¿por qué se da? ¿Por qué no pasamos a un on-label? Bueno, ¿cómo disminuir este riesgo, ¿no? Que tenemos de efectos adversos que tal vez no se estén documentando? ¿Cómo disminuir este uso off-label que tenemos actualmente en pediatría? Y cómo promover, pues, que tengamos más un on-label.
Es un tema bien interesante, doctora. Fíjate que tenemos pendiente exactamente atender el off-label. ¿Por qué se da? Pues porque no hay inversión para paciente pediátrico. Y además, las implicaciones de los estudios clínicos de nuevos medicamentos en pediátricos no son tan sencillas. Primero necesitamos la autorización del tutor y que además garanticemos que de verdad va a haber una mejora clínica para el paciente y normalmente el riesgo no se quiere asumir. De hecho, por ejemplo, hay tratamientos para el manejo de leucemia que se siguen utilizando protocolos bastante clásicos, por ejemplo, el de San Jude 16, comparado con nuevas terapias, por ejemplo, con una terapia de CAR-T, que precisamente no se dan los cambios porque se le tiene miedo. Entonces, si hay mucha resistencia, entonces necesitamos hacer que más incentivos para que la industria farmacéutica se involucre más con los nuevos tratamientos. Necesitamos tener muchos equipos multidisciplinarios muy especializados en paciente pediátrico, pero sobre todo dar seguimiento a los protocolos. Necesitamos tener una inversión en formación y una inversión en investigación, tanto para la industria farmacéutica como para los profesionales de la salud. Necesitamos que se desarrollen protocolos, por ejemplo, de formulaciones magistrales, que sin duda alguna los estamos atendiendo y que pueden ser esas incluso propuestas para que haya nuevos medicamentos. Sin embargo, necesitamos estudios y esto requiere recursos, ¿no? Para que nosotros podamos decir que a lo mejor una nueva suspensión pediátrica que se desarrolló magistralmente puede realmente dar un registro para la industria farma y ser segura, nosotros necesitamos hacer los estudios de estabilidad, necesitamos hacer estudios de compatibilidad y eso involucra una inversión muy fuerte. Entonces, ¿qué necesitamos? Que todos los actores nos responsabilicemos de la importancia del paciente pediátrico y que en realidad se atienda como una campaña, no diría solamente nacional, sino internacional, el diseño y desarrollo de nuevos medicamentos específicos y que sobre todo, pues cuando hay esta tendencia que muchos laboratorios den, quienes estamos involucrados creamos en que es el mejor camino para mejorar la calidad de vida de los pacientes. Si seguimos dudando de la innovación, pues seguimos estancados en un loop donde no vamos a pasar a este on-label y vamos a seguir por muchos años con el off-label. Y nos pasa mucho, yo decía mucho en algunas patologías, como los tratamientos oncológicos, pero también nos pasa para crisis anticonvulsivantes, nos pasa para medicamentos antihipertensivos. es un monstruo de medicamentos que tenemos en esta indicación fuera de lo que sería la seguridad del paciente, pero me parece que la campaña debería ser global para empezar a impulsar el diseño y el desarrollo de estos medicamentos.
Totalmente de acuerdo, doctora. Excelente respuesta. Y bueno, también esto va unado justo con la siguiente pregunta que nos están haciendo para el maestro Heriberto. Tanto la falla terapéutica como cualquier evento adverso derivado del off-label, pues debería ser notificado. Sin embargo, nuestros sistemas de notificación, pues muchas veces están un poco inmaduros, ¿no? Al momento de que queremos concientizar y sumar las notificaciones, pues resulta que no tenemos muchos datos. Entonces, usted, maestro Heriberto, mencionó que los datos, pues es la fuente para el análisis y la prevención. Entonces, en ese sentido, ¿qué acciones desde calidad se fomentan o se recomiendan para incluir a más profesionales de la salud en la cultura de seguridad del paciente y sobre todo que este tipo de eventos y de errores que pueden generar daño en nuestros pacientes pediátricos, pues lleguen a una central y que sean analizados para poder prevenir en el futuro?
Sí, pues bueno, en realidad me parece que primero el enfoque de los sistemas de notificación no deben ser no punitivos. Es decir, tenemos que promover en las personas que el hecho de que hagan una notificación no significa que se van a hacer señalamientos, castigos, etcétera, sino la notificación tiene el objetivo justo de identificar las causas que generaron este evento adverso o estos errores. Entonces, en este sentido, pues es justo ir permeando esta información, sensibilizando al personal de lo importante que representa la notificación. Y me parece que un tema también fundamental es la atención de de las personas que notifican como segundas víctimas. Me parece que es un tema que tenemos que retomar porque si bien estamos analizando el riesgo o el daño que se ocasionó a los pacientes, también tendremos que analizar el impacto que le representa desde el punto de vista emocional y psicológico a las personas involucradas en esta condición. Entonces, a esto le llamamos justo los programas de segundas víctimas. Es decir, tenemos que hacer esta estrategia o implementar esta estrategia de tal manera que las personas que hacen esta notificación pues tengan el mayor número de herramientas desde el punto de vista de la sensibilización para generar mayores reportes de incidentes relacionados con la seguridad del paciente. Es decir, tenemos que atender también a las personas involucradas y, por supuesto, también sensibilizar sobre la importancia que tienen los reportes de información.
Perfecto, pues ese es lo más importante, ¿no? Incluir justo al profesional dentro de todas estas actividades, pero no olvidarnos de esta segunda víctima que es el profesional de la salud que está involucrado en este tipo de eventos, que desafortunadamente pues está en un shock, ¿no? Al final del día nadie quiere hacer daño dentro de la atención y mucho menos nadie quiere hacer daño a un niño, pero a veces los sistemas en su inmadurez o bien los sistemas pues no son infalibles, pues desafortunadamente ocurren este tipo de eventos. Entonces, el fomento de estos datos es fundamental para prevenirlos. Doctora Mara, nos preguntan, ¿qué recomendaciones daría para evitar errores de dosis por falta de ajuste en situación de enfermedad renal?
En el caso de la enfermedad renal, pues siempre hay que consultar a la literatura. Sobre todo hay un listado de medicamentos antibióticos donde tenemos la lista de medicamentos que podemos y debemos ajustar según la tasa de filtración glomerular. Y hay algunos que incluso se pueden remover con los procedimientos dialíticos o que debemos de dar una dosis adicional si el paciente se está dializando. Entonces, en el caso de la falla renal, pues siempre es conveniente revisar la dosificación para estos pacientes y hay mucha información que se va agregando continuamente en la literatura. ¿no? Pacientes renales, hay que tener mucho cuidado con el manejo de medicamentos.
Claro. Última pregunta para usted, doctora. ¿Cómo impactan los medicamentos vía oral en la microbiota de los pacientes pediátricos?
Esto es muy, muy importante porque no solo impacta en la microbiota, sino que la microbiota tiene otras funciones y también pueden formar metabolitos. Ahí hace falta también mucha investigación al respecto, pero por supuesto que el tipo de medicamentos que estamos dando, sobre todo antibióticos y demás, impactan en la microbiota y ahora hay una serie de prebióticos y probióticos que se han estado proporcionando a los pacientes pediátricos y más bien nos falta mucha información al respecto.
Totalmente, ¿no? Y por ahí decía, ¿no? Es el segundo cerebro, ¿no? Nuestra microbiota que tenemos y pues en nuestros niños que se está formando, que está madurando, pues definitivamente tiene un impacto significativo. Como bien mencionan, hace falta mucha investigación, sin embargo, hay datos por ahí que la microbiota, pues el cambio también te va a generar cambios en el humor, cambios a nivel del sistema nervioso central y bueno, todo esto impacta también en el desarrollo de nuestros pacientes pediátricos,
Y
¿no?
metabolitos, también hay fármacos que se metabolizan por la microbiota. Entonces, en realidad, pues nosotros somos quienes tenemos que generar esa información, nosotros que trabajamos con los niños, ¿no? Es
Así es,
nuestra
doctora.
responsabilidad,
Es
¿no?
nuestra responsabilidad. Ya nos dejó más tarea entonces esta pregunta, ¿no? También tenemos una pregunta para la doctora Liz. ¿Cuáles son las habilidades que debe desarrollar un farmacéutico clínico para contribuir a las barreras de seguridad en la atención de los pacientes pediátricos? ¿Qué recomienda, doctora?
Bueno, es bien importante, yo creo que a nivel hospitalario diferencial que tenemos que tener dos farmacéuticos, uno que está totalmente enfocado al sistema de medicación y otro que es clínico, que es el que nos va a dar el acompañamiento en lo que va a ser la farmacoterapia. Y eso tiene que ser especialista en farmacología clínica pediátrica. Y a veces hasta atreverme a decir, hasta con subtítulos, porque a veces tendrá que ser para pacientes que tengan trasplante, para pacientes oncológicos, para pacientes con diferentes necesidades terapéuticas, porque no podríamos decir de ninguna forma que un farmacéutico clínico va a saber para todos los pacientes pediátricos. Necesita estar súper especializado y súper enfocado. Entonces, la primera habilidad sería esa. Después, habilidades de comunicación, las famosas soft skills o las habilidades blandas. Necesitamos de liderazgo, de comunicación, necesitamos hacer nosotros comunicación técnica, científica, pero además social. Necesitamos ser sensibles a las necesidades de los pacientes y además nosotros necesitamos aprender a liderar grupos de farmacología clínica. Necesitamos poder dar comunicaciones, pero además ser expertos en farmacovigilancia y en seguridad del paciente. Entonces, me parece me atrevo a decir que hay muy pocos de ese nivel para paciente pediátrico y bueno, sin duda alguna la doctora Lili es de los que representan estos grupos y me parece que hay pocos hospitales a nivel nacional y también a nivel internacional con ese nivel de formación para atender al paciente pediátrico. Creo que los dos principales de tercer nivel en la Ciudad de México están en ese camino haciendo una gran batalla y me parece que si mencionamos todas las habilidades blandas, podríamos dar una sesión completa de los requerimientos, pero con que se cubrieran estas que he mencionado previamente, creo que sería más que suficiente.
Totalmente de acuerdo, doctora. Y siempre, ¿no? O sea, al final no se termina de aprender todo, ¿no? O sea, siempre está en un constante aprendizaje y eso es lo más importante para cualquier farmacéutico. En Latinoamérica en general, pues el farmacéutico le falta más visibilidad como parte del equipo de la atención de salud, a diferencia de otras latitudes. Entonces es una lucha prácticamente constante, pero que hoy lo mencionamos también porque el farmacéutico en general va a ayudar a disminuir los daños que tengamos en nuestros niños. Y eso es algo que debe prevalecer para que podamos establecer equipos multidisciplinarios y obviamente con todas estas hard skills y soft skills que te debemos de tener y que vamos aprendiendo sobre la marcha, doctora. Muchísimas gracias. Y bueno, ya para finalizar, la última pregunta de nuestro público, al maestro Aliberto, que si nos puede platicar cómo está haciendo esta conciencia en los profesionales de la salud, especialmente en nuestros pediatras, ¿no? No solo a nivel hospitalario, sino a nivel comunidad. ¿Qué es lo que desde calidad se está generando y qué efectos ha tenido en la comunidad, maestro Heriberto?
Sí, pues creo que el permear las experiencias con el resto de los profesionales es una tarea fundamental y es una misión que tenemos en el instituto. Y con respecto a esto, bueno, pues en el hospital se ha formado un programa que se llama Cuidados de Transición al Hogar, que es prácticamente una iniciativa que se ha establecido por la Young Commission, en el que tenemos una mayor número de participación del cuidador primario. Entonces, estos cuidados de transición, pues han tenido una muy buena respuesta, sobre todo porque es un espacio en el que hemos podido contribuir a que los pacientes que van a egresar del instituto pues tengan la información suficiente antes de su egreso. Y que además, pues bueno, este grupo de personas que se ha conformado, pues además dan un seguimiento a los pacientes, ya sea por una llamada telefónica, por un chat, que a lo mejor no es todavía muy formal el mecanismo, pero que de alguna manera eso ha creado una cierta confianza en este espacio que se ha creado para ellos, para darles esa información y atención en el momento que se necesita sobre el cuidado de su paciente, tanto si es el paciente que está en posibilidades o de los cuidadores primarios.
Excelente, ¿no? Pues, y eso es algo muy importante y creo que todos estamos de acuerdo, o sea, al menos en los hospitales, en las instituciones de salud, hay un profesional de la salud, pero en casa, en la comunidad, difícilmente. Entonces, el cuidador y el familiar toman un rol importantísimo en la prevención de daño en nuestros pacientes pediátricos. Entonces, este mensaje no solamente va para profesionales, va también para aquellos cuidadores, aquellos familiares, papá, mamá, que están a la atención de los niños, pues justamente ver qué es lo que está sucediendo, ¿no? Siempre preguntar sobre las dosis, preguntar al médico sobre los diagnósticos, preguntar sobre los tratamientos y siempre estar al pendiente de las letras chiquitas, dirían por ahí, porque es ahí donde tenemos la mayor frecuencia de errores con daño en estos pacientes pediátricos. Entonces, es un mensaje que va para toda la comunidad y felicito al maestro Heriberto y al Hospital Infantil de México por esas acciones de transición a casa para que tengamos una disminución de daño. Y bueno, pues con esto desafortunadamente hemos llegado al fin de nuestra sesión. Muchísimas gracias a todos por conectarse, a ustedes, mis ponentes queridos, por hacer de esta sesión fantástica, llena de conocimiento, pero también de mucha energía para que podamos establecer un cambio en la conciencia de todos nosotros en seguridad del paciente, especialmente de nuestros niños y neonatos. Por su invaluable tiempo, muchísimas gracias por su contribución a que este evento fuera un éxito. En verdad, estamos generando un cambio desde la Sociedad Internacional de Farmacovigilancia. A todos nuestros asistentes, por favor, sigan compartiendo en redes sus experiencias, en comentarios sobre el Patient Safety Day de ISoP 2025. Y recuerden que si quieren ver el video de cualquier sesión, lo pueden ver desde Facebook o bien desde YouTube de las páginas oficiales de ISoP Online. Entonces ahí estaremos publicando las grabaciones de los eventos en los próximos días. Si aún no eres miembro ISoP, te invito a que lo seas, a que formes parte de esta red internacional comprometida con la innovación científica y educativa en farmacovigilancia y con la promoción del uso seguro de medicamentos a nivel global. Entonces, a nombre de la Asociación Internacional de Farmacovigilancia, ISoP, les doy nuevamente las gracias por su participación en esta sesión y justamente en el resto de las actividades de la edición 2025. Y bueno, pues además, como región LATAM, pues nos toca cerrar este siglo de sesiones que fue conmemorativo del Día de la Seguridad del Paciente, la seguridad del paciente desde el nos mandó este mensaje clave. Este año nos unimos con convicción y compromiso para visibilizar un mensaje que no puede esperar. Tenemos que tener cuidados seguros para todos los recién nacidos y para todos los niños y las niñas. Porque la seguridad del paciente pediátrico no es solo una responsabilidad técnica, sino es un acto de humanidad. Cada niño merece crecer en un entorno donde su salud esté protegida desde el primer latido, desde el primer contacto con el sistema de salud. La farmacovigilancia en este contexto se convierte en una promesa, la de velar por el bienestar con rigor, sensibilidad y con acción coordinada. Agradecemos profundamente a todas las regiones que hicieron posible este encuentro global, a Middle East, África, Europa, Western Pacific, South Asia, Indonesia, China, Norteamérica y obviamente Latinoamérica. Su compromiso colectivo ha sido el motor de este evento. Un reconocimiento especial a las coordinadoras regionales, cuyo liderazgo y dedicación marcaron la diferencia. A Patricia Zuluaga, Constanza Moreno Fernández, Andrea González, Paola Camargo, Gita Benadabda, Zaira Vargas, Ana Lucía Flores y Alexia Pontifese. A Ángela Caro y todo el comité ejecutivo de ISoP, muchísimas gracias por siempre la gestión y apoyo para que este evento ocurra. Nos despedimos con la certeza de que cada acción cuenta y que juntos seguiremos construyendo un futuro más seguro para todos los pacientes desde el comienzo. Nos vemos el próximo año. Que tengan una excelente tarde, una excelente mañana. Y bueno, en México pues tenemos ahorita un simulacro. Que tengan un excelente día.
Muchas gracias.